funding to address cross-border issues. And we've also been advised that TB services have been endorsed for integration into the border for us. In order to address TB at the workplace, we have also engaged Ministry of Public Service, and discussions are underway. So we hope that in the future, we'll be able to enhance issues around addressing TB at the workplace, including facility level. Under service delivery, again, apologies for the service delivery was raised, and this really came out more than 1,500 cases of TB that were identified during that period of about a month. Under community engagement, the issue that was raised was a limited community engagement with a recommendation to strengthen community awareness. And we've had targeted activities that have been implemented particularly by USTP and the different implementing partners, engagement of political, religious, and cultural leaders. And I think some political leaders are also part of this session, engagement of the Parliamentary Caucus on TB, as well as engagement of community level, the gatekeepers within the communities and survivors. We've also been able to orient civil society organizations, as well as TB survivors. We do have an orientation package that has been used to orient these different stakeholders, and we believe that they will support in terms of improving community awareness. Yesterday we learned that it is better to have a bottom-up approach, so we think that engaging the community teams is a way in which we can really implement the bottom-up approach. In terms of private sector engagement, so you believe what I'm saying, apologies if you're not able to see. In order to enhance private sector engagement, there's an ongoing inventory of private sector. Yesterday we had in from the representative of the private medical practitioners, and I want to say that we have initiated steps to address some of the issues that you raised. So with support from Defeat TB Global Fund, we've been able to develop an orientation package that can be used to ensure that private sectors improve service delivery for particularly TB. We've been able to support some districts to map out their private health facilities around them, as well as train them and mentor them. So we know that moving forward, we'll have more districts that are brought on board to improve delivery within the private sector. So the other thematic area was to do with digital innovations, and we really did document the role of digital platforms in the context of COVID. And with regards to availing TB analytics, we know that we have engaged the Emergency Operations Center at the Ministry of Health, and we are also using the e-case-based surveillance system, as I already mentioned. So, but also on a weekly basis, we are able to pick data from the different facilities regarding TB screening and case finding. And we've also been able to scale up these innovations to various facilities and districts. Under research and development, the use of operational research was emphasized, and we have also been able to scale up successful innovative treatment success rate activities. So we are moving away from the pilotitis syndrome. So we are scaling up. We pick on successful innovations and take them to scale, and we think that that will really support us in reaching our goal. And we were also able to use information from the study that was conducted on bidirectional TB screening, TB COVID screening, to improve or enhance our algorithm. And we are able to identify more people with TB. On a monthly basis, we do have the research, the different stakeholder information also informs policy. In the era of really declining funding landscape. So we know that we work as a team in terms of the different stakeholders. We've been able to listen, and this has really been emphasized during the era of COVID-19, where we have used the different resources to intervene for both TB and COVID. And that is the end of the presentation, and ending TB and leprosy by 2030, I think is achievable. Thank you very much.
Oh, thank you very much, Maureen. You can. May I also request the younger person who is coming to share with us the experience to come up here. And as of now, I'm now ushering in our friend, Dr. Kenneth Mutesa-Sira, to come and give us issues of quality improvement and innovative approaches. Doctor, as you take up to present, in the audience, you will see the signposts giving you warning on time. So take keen attention of the time up cards, not the ready card, but the cards for time. Thank you very much.
Thank you very much, Chair, and good morning, ladies and gentlemen in the room and online. My name is Kenneth Mutesa-Sira. As I wait for the projection, I work for the USAID Defeat TB project. USAID Defeat TB is a 5-year technical assistance mechanism that aims to increase TB case notification and treatment success rates. The project is in the 5th year of implementation. So, Chair, as you have mentioned, my talk is going to be about continuous quality improvement, and I'll aim to highlight the lessons and opportunities we have to be able to innovate and to be able to catch up on targets, but also to be able to implement the people-centered NSP. Ronald, I think this will not move. Sure, thank you. Yes, so I've already mentioned the objectives of my session. I'll just go over very briefly the quality improvement framework. I'll go over how to design a collaborative, some key results, and then, very sorry about that, and then the lessons and the call to action. So this slide highlights what we are saying. What is this quality improvement we are talking about? There are 3 messages on this slide. One of them is the framework, which highlights that as we look at the norms, the guidelines of how we deliver care, we need to look at aggression. All the messages I'm going to send out because we have collaborated with many stakeholders in the room and online to be able to achieve this. So once one team is able to test innovations, and once we have more teams testing the same innovation at the same time, then we are able to achieve the desired target or goal. So very briefly on how we designed this, I've summarized it into 4 steps. The graphic on the right really is spoken to by the wording. Where we have the startup phase, we identify the area for improvement. Yesterday we saw the performance, and we are going to be able to look which priority areas do we need to improve. Identify aims, identify sites, collect data, form teams to be able to start the improvement work. For those working on the TB and TB-HIV collaborative, I think you can see where you lie, whether you are still in startup or whether you're already in the action phase. In the action phase, is where we have coaches going out to the facilities to support them to do the root cause analysis. What's the cause of the gap? What can we do to be able to address the gap? So they coach them, they test changes, and they also monitor their improvements using the data. The consolidation phase, which is number 3, is where we now pick up the lessons and package them into what we call change packages. You have all seen the SCF change package, you've seen the TSR change package. This is the process that we go through. And then the scale-up phase, I think this is where we are, if we are going to be able to achieve the targets, is where we have multiple sites implementing these evidence-based changes that work. So this, very briefly, is the journey of quality improvement for TB programming in the last 4 years. It's only a reminder for many of us because you've been for facilities countrywide. They were able to look at different processes. Here I'm highlighting data for screening. As they increase screening in their patient care departments and evaluation of the patients, we see that the notification improved during the intervention phase. And it improved and was even sustained beyond the intervention phase. I say intervention, this was a period of intensive site support, monitoring, use of data, peer learning activities. And the lessons here have been packaged and used for the national scale-up, which is what we are really aiming up as we drum up to catch up on targets. Moving on to treatment outcomes, the TSR, as you heard from the Honorable Minister yesterday, had stagnated at 72% for several years. And we knew that it was high loss to follow up. It was death that really affected treatment outcomes. So the Minister of Health, together with Defeat TB and partners, looked at the drivers of TSR and quickly recognized we need to be able to work on retention, we need to improve treatment monitoring, we need to work on documentation, and also we need to make sure that there is adherence. And so we developed a package of change ideas. This package has been tested, really centered around the patient, making sure the patient is educated and engaged throughout the course of treatment. As you know, for many facilities, this is done by the health workers and the community workers, but we also know, as you have heard from Dr. Maureen, that scaling up of digital technologies is coming up and it eases this process. Working on care systems, we've talked about clinic days, appointment systems and reminders, again, where there are digital technologies much easier, but even health workers are able to work on that. And then we have the community engagement. I think I shouldn't say much for this. They help support adherence, retention and tracking. Documentation has been key, and also using the data on dashboards to engage leaders to demand for accountability. This is a lesson we picked from one of the regions in West Nile. And for those in the room at the back, there's a similar dashboard which is used for the leaders to demand for accountability. So we looked at a few sites that quickly picked up this, and as they worked on their retention, you can see they focused on their clients, they're able to retain them in care, they improved the documentation of outcomes, and we had continuous learning and sharing of lessons from these teams. And I think you saw some of these maps yesterday. The one on the left is showing you where the country was during that particular quarter. You can see more reds than yellows and greens. And then the one on the right shows us the movement across the country. All regions are picking up on lessons, doing something, and I really want to appreciate all the regions that are making an effort, all the districts that are making an effort to shift from red to green. Red is less than 73%. Green is 88% and above. And so we can make that whole map green if we continue and also sustain what we are doing. So on to prevention, and I just want to reflect on the TPT surge that we had in 2019. This graphic you see was the thought behind the response to accelerate TPT. You have inputs, you have processes, you have outputs, and how we retain the clients so that TB is prevented. Now, for quality improvement, we focused on the processes. How do we identify the eligible clients? How do we ensure systems are in place for them to access treatment? How do we ensure we are able to document? Of course, after making sure the inputs are in place. And again, I'll remind you of how this summative collective effort yielded a good result in 100 days. Started with a few facilities, but as the learning was shared and more action taken in the different regions, we saw an enrollment of 363,000 PLHIV in 100 days. And that was not comparable to the number that had been enrolled over years. So the lessons, again, we picked and were able to share along the way that when you work with the patients, you engage them, you work on the commodities, you have the healthcare workers, you work on the systems of delivery, then you're able to achieve your target. And you use your data to monitor frequently, just the way we did as a country. So I also mentioned about TB and TB HIV cascade improvement, and this is really, really early work. I want to draw your attention to the third column. That is one site. As you can see, the very extreme, they had reds on most of the indicators. Those are cascade indicators. Believe me, I know they are very small on the screen. But as you move to the right, you see movement from red to green, and those are other sites that are working. Of course, there are columns which are red throughout, and that is still work in progress. So we want to encourage all the regions that have started this initiative to be able to scale it up. Hopefully, we shall have more results during the next conference. So as I wind up, the key lessons we picked up is that the CQI platform is very useful and effective at improving case notification, treatment outcomes, and prevention. And it can be used to actually close in on the gaps of our targets. And if we need to achieve a national result, we need to be able to scale up and to decentralize this effort. And as I mentioned, right now, the focus is on moving in the cascade improvement to improve QR rates. Our QR rates are still very low. Prevention is still behind. And also, even the TSR is not yet on target. So the call to action, and this is almost the last slide, is to support the scale-up and consolidation of TBQI initiatives. There are different stakeholders in the room, in the regions. Each one has a role. It could be funding, it could be capacity building, it could be doing at the facility. So we really call you to that action. We need to sustain skills building, because it's one of the challenges we have observed, both for coaches to sustain this work, but also for site-level teams. And there's a lot of knowledge, so we need to address the no-do gaps.
Time up.
Yes, thank you very much. So I acknowledge all the stakeholders listed on that slide, and I thank you so much, Chairman and organizers, for the opportunity to present. Thank you.
Thank you, Doctor. Next is a young person. This young person is called Nyanzi David. Nyanzi David is a comrade to me because I myself, I am a TB survivor. So can we give a round of applause even before he presents? Standing out and tell the people I lived with TB is not an easy task. But the unfortunate part is Nyanzi will present in our local dialect, Luganda, and therefore bear with us. Tandika Sebo inewa dakika zotano.
Mwasuze mutya banyabo ne basebo. Amanya gange bampita Nyanzi David. Nviridde bwayise. Nali nkola nengenda ndwala akalwadde ke bayita akafuba.
Just a minute, Nyanzi. Mwami Dr. Musesasira ajja kuyambako kuvunula byoyogera. Bw'oyogera ng'obaako w'okoma n'avunula. Weebale nnyo.
Nenumbibwa akalwadde ke bayita akafuba, naye nali simanyi kituufu kinnuma. Kakati nga mbeera nkololakolola. Gye nali mbeera ne bakubira ssenga wange, najja n'aŋŋamba ne tugenda e Mulago. Bwe twatuuka e Mulago ne bankebera ne banzuulamu obulwadde obwa TB. Obulwadde obwa TB ne baŋŋamba ŋŋenda tutandika eddagala. Eddagala ne baŋŋamba ogenda ddimirira emyezi 6. Ne mbuuza omusawo ne mugamba naye emyezi 6 nga mingi. N'angamba ky'olina okukola. Eddagala ne nditandika naye tekyambeerera kyangu. Kuba baŋŋamba olina oddimira nga tonnaba kuteekayo kyakulya kyonna. Ne ntandika ne ndimira naye ne baŋŋamba ky'onooba olabye kyonna tobaako kiweekanga. Nagendanga okufuluma oba okufuka nga nfuuka yero. Naye nga buli we mmala oddimira libeera lirina okuntwala emmanju. Ne ndimira paka bwe nalimalayo ne mmalako emyezi 6. Ne yanziza kumpa olukisa luno.
Okay, thank you. Dr. Mutetasira, can you please give us a synopsis?
Yeah, Mr. Nyanzi has briefly told us about his journey, how he, while at work, he developed an illness which he was not so sure about. It involved coughing and fevers, and for a while he didn't seek care until he talked to an auntie who directed her where to go. So she went to Mulago. He was tested, and he was told the diagnosis of tuberculosis. Now, when he was told that the duration of treatment was 6 months, he was concerned about the duration, but he was cancelled and was able to take all his treatment, and he completed. Chair, we haven't heard from him on whether he had any major challenges with the treatment. Okay, he talked about when he would take the medication, and I think he could get some stomach upsets. I think, sorry? And the urine color change. But I think the team was able to handle, and he said he completed his treatment, and he really appreciates the opportunity for him to tell his story here. Thank you.
Thank you, Doctor, for that interpretation. Yeah, as I told you, personally, I experienced that, and earlier before Nyanzi with the big tubs, it isn't easy. We took a long time. And as we talk about TB, I also wanted to share with you that we shouldn't take lightly the issue of leprosy. I happen to have grown up with a grandfather who had been affected by a disease leprosy-like, and he never had his other toes other than the main one. And as we grew up, they would tell us, these are the children whose grandfather has a Kajambia leg. You know Kajambia leg? That is a panga leg, because it was single and it didn't have the what? The other toes. Whereas with the TB, you will get it and you either die or you treat it and you get healed. With the leprosy, you live with it, and it takes long. If it must lead you to your death, you will live with the stigma. You will live among people who discriminate you. So we also need to give that attention, and especially for those of us in this room who are in charge of policy, in charge of programming and management. In the 60s, this country had very good infrastructure for leprosy. It is all gone. In some places, it has become health center 3s, which are not targeting leprosy. In some places, they have built seed schools there. They have built headquarters of sub-counties. So we need to have that reclaimed because it is still with us. And in some cases where people have addressed river flies, the focus has been on river blindness. It has not been on the skin effects of the river flies. That was something I wanted to push in now. Unless I'm asking if you have 2, 3 issues burning to ask these presenters who want to wind up and go into the next session. Can I now open up to the audience? Yes, I can see one, two. I stop at that, and our brothers on digital, if you can pick some two, if they are there online, we also pick those ones. Unfortunately, we do not have mics moving around. You can now use this standby. Our second person there, get online for your questions.
Yes, good morning, everyone. My question goes to our TB survivor adolescent, Mr. Nyanzi. As a person from the constituency of the private practitioners, I would love to know your experience during that period before you were actually diagnosed from Mulago as suffering from tuberculosis. Wagendako mu ddwaliro ly'obwannannyini lyonna mu kliniki okufuna obujjanjabi era wagambibwa ki? Probably your feedback would be important for our own consumption and where we need to improve. Thank you.
Nyanzi lindako oba jangu eno nga bwe tulinda oddemu ekibuuzo.
Good morning, everyone. I'm by the name Gualmoses, DTLS Soroti District. My question is about TB catch-up. Of recent, they did TB catch-up, but whenever we go out there for support supervision, they will always ask, when are they going to pay us for that activity? That's all I wanted to know. Thank you.
Thank you very much. Therefore, there are two questions. Katutandike ne Nyanzi. Jangu wano demo kozesa akazindaalo ako. Ekibuuzo wakitegedde mwami Nyanzi?
Yes, sebo. Eddwaliro lyonna saayina ddwaliro lyenagendamu kubanga senga gwange bwe yajja abantu nga nabo bamugamba nti mutwaleko e Mulago. Kati bwe twagenda e Mulago gye natuukira ne batwala ku laabu ne banzijjako omusaayi ne bankebera nga nnyina TB.
Sorry, Nyanzi, atubuuzizza agamba nga tonagenda Mulago kubanga TB atandikanga ekifuba ng'ekya bulijjo. Wafunako obujjanjabi bwonna mu kalwaliro konna ate owotuukira ogenda e Mulago wali mu mbeera ki?
Bwe nagendera e Mulago nali nga mbeera mpulira empewo nga mbeera nkololakolola nga bwe nkolola nsesema naye siina ddwaliro ddala lye nagendamu natuukira Mulago.
Okay.
Yeah, so Zubairi, Mr. Nyanzi says he did not attend any private facilities. I think it was the auntie who took him to Mulago. And he mentions the symptoms he had when he went to Mulago. He was coughing, he was vomiting, he was weak. And when he went there, he had the evaluations done, and that is where he started treatment. Thank you.
TB catch-up.
Yes, sir. Thank you very much. The person who asked the question. Specifically, the question was related to payments. As we shall hear from our colleague, we did have an activity that was focused on community screening and diagnosis. I want to reassure you that the process is underway and the teams that participated in that activity will be paid.
Team online, is there any questions online? If there are none, now I want to request all of us to give an applause to this team as they leave the podium, and I invite the other team when we go to the program of today. Thank you very much. Dr. Maureen, Dr. Kenneth, and David Nyanzi. Thank you very much. May I now start by requesting the chairman of the next session. My duty here is not chair, my duty is to MC, but because of this catch-up is why I took on this to handle the backlog. Now I'm now requesting the chairperson of the next session, Dr. Inidi Mbabazi, to come and take your seat. Then you will invite your presenters. Dr. Inidi Mbabazi is team leader, Health Prime Minister Delivery Unit, PMDU in the Office of the Prime Minister of the Republic of Uganda. Dr. Inid, is there somebody else to stand in for Inid? If not, I am again putting you in overdrive. Okay. I was nearly engaging overdrive. Maybe in the meantime now, can I also be inviting the World Health Organization Afro presenter for global and regional progress to come over, then the OPM MF coordinator to come, and the Principal Assistant Secretary, Minister of Works, also to come over so that we move fast. The presenters for this session. The presenters, please. Our presenter on global. For your information, for those who have questions, we have a stationary mic in the other corridor. Once you are given opportunity to ask the question, you will come forward to the mic. But that mic is controlled from the control room, and the control room will help us. I take the pleasure to hand over the session to the session chair to moderate. Thank you.
Thank you very much. Former chair, if I can refer you to
Now
former
I'm
chair.
the MC.
MC? Okay, thank you very much, MC. Good morning, colleagues. You seem to have succumbed to the bad weather this morning. I would like us to cheer up because this is a very important session, and I request a volunteer to give us an energizer. If not, we can sing the national anthem because this is a national event. I need your consensus on this before we start this important session. Consensus, what do we do? Do we sing the anthem? Do we get an energizer? Energizer, who will give us an energizer? Okay, thank you very much, volunteer. Go ahead.
So have some space around you. Good. So 1, 2, 3, we go. There is a land by the sea. Some people are not doing it right. There is a land by the sea. But the land was never seen. There is a tree on the land and the land by the sea, but the land was never seen. Oh, but the sea was never seen. Okay. There is a nest on the tree, and the tree on the land, and the land by the sea, but the land was never seen. There is a nest on the tree, and the tree on the land, and the land by the sea, but the land was never seen. You speak that once again. There is a nest on the tree, and the tree on the land, and the land by the sea, but the land was never seen. Thank you so much.
He deserves a bigger clap. And also, we appreciate the fact that you left your beds and homes early, and the stomachs must be complaining. But we shall rush through this session and make sure that you don't run out of energy. So my name is Ini Dimbabazi, doctor. I am the team leader for health at the Prime Minister's Delivery Unit in the Office of the Prime Minister. And I sit on the Secretariat for the Multi-Sectoral Accountability Framework for TB, specifically on the OPM side, backstopping the technical team at the Ministry of Health. And yesterday there were lots of issues about coordination and the need to employ a multi-sectoral approach to this disease as we gear our efforts towards ending the epidemic by 2030. And allow me to begin by taking roll call in that context of the multi-sectoral approach. Those of you who have the multi-sectoral accountability framework for TB booklet, you can refer to page 15. Would like to know who is here before we start our conversation. Office of the President or the Presidency? Yes, there was another DC yesterday. Thank you very much. And please, if you have the booklet, refer to the page that stipulates your role. Would like to hear the voice of the presidency in the fight against this epidemic. Office of the Prime Minister. Yeah, I'm here with Gertrude. Parliament. The caucus was here yesterday. Parliament. Yes, Parliament. I'm sure they'll be joining us. But they have a very big stake in this, and their roles are stipulated in the booklet. Minister of Health, of course, you're here. Education and Sports. Let's see who is from Education and Sports. They must be busy discussing the opening of schools, but we need them. We know that the students can be change agents in the community, but also the issue of overcrowding in the dormitories where you find 3 daycares, each with 2 people, 3, and that is fertile ground for TB transmission. So we need them. The message should get to the Minister of Housing. Yesterday, the caucus referred to housing as a big stakeholder. Do we have housing? Oh, they are online. Oh, apologies for our online participants. I hope we'll be able to capture their views, and I'm sure some will make their presentations via Zoom. Minister of Local Government and Local Governments. Okay, thank you very much. Refer to your roles. Ministry of Justice and Constitutional Affairs. Minister of Agriculture, Animal Industry and Fisheries. Ministry of Finance, Planning. Ministry of Works, Transport. Thank you very much. Minister of Energy and Mineral Development. Energy. Energy, the mines, the oil is coming. In the mines, we know what happens. Those minerals that predispose our people to lung disease and eventually TB. Where are they? I hope they are online. Minister of Internal Affairs. Internal Affairs, they were here. I guess that's where the prisons fall. Okay, Minister of Information, ICT. We need them. We need them to spread the word. And Dr. Stavia and her team, yes, they have come up with very good, a summary of important information that needs to be passed out. We need to see them talk about TB at the media center, starting yesterday. Minister of Gender. Gender was here, and I'm sure they are still around. Trade and Industry. Defense and Security. Public Service. Technology, Science and Innovation. Academia. Dr. Katamba, you fall there. Yes, we expect you not to ask questions in your presentation, but if you think the targets are unrealistic, you're going to tell us how you propose solutions. We need solutions from you on how we shall realize those targets. We need the innovation. Funding agencies, you're here, and we appreciate USAID, CDC, and others for the support. Without you, the story would be different. Civil society organizations, thank you. Community advocacy, community leaders, political, cultural, religious, celebrities, cultural icons, where are you? Yeah, but Baby Cool was very key in the development of the framework. Today he's not here with his team. Okay, private sector. Private sector implementing partners. Yeah, I remember Baby Cool presented very good initiatives that they were doing during their shows to prevent TB. Implementing partners, thank you for supporting us. We heard you yesterday, and we shall continue hearing from you today. Technical agencies, academia. So, you will tell us who we have left out during the discussions, if we need to add on this list. So thank you very much. I'll invite the first presenter. So far we have one here, and I would like to confirm the Secretariat, please confirm whether WHO Afro is online, and then the Ministry of Works. As you do your consultations, I will invite Gertrude Namayanja from the Office of the Prime Minister to take us through the first presentation. You're welcome, Gertrude. Who takes the podium? I would like to remind us on the theme of this session. It is beyond the health sector to end the TB epidemic, and that's why we did the roll call, beyond the sector. Gertrude.
Thank you very much, Dr. Enid Mbabazi. Good morning, ladies and gentlemen. I'm Namayanja Gertrude, Principal Policy Analyst, Office of the Prime Minister. I work in the Directorate of Strategic Coordination and Implementation. Basically sitting in for my commissioner, Jose Stejeza, who is not here, but on similar national events.
Voice, Gertrude.
I'm representing Commissioner Jose Stejeza, who is not here, but he sends his apologies in this regard. Allow me to thank the Ministry of Health for steering us this far in the fight against TB. And without wasting lots of time, I request that I have my presentation. Yes, I have my presentation. There we are. Whereby I will be giving a presentation on the multi-sectoral accountability framework for TB, how we are coordinating this, the fight against TB, and also registering the progress. Just a brief overview. By way of just a brief background, you'll understand that, not that it's not working. You'll understand that previously, the fight against TB was more or less a health-related issue. Everyone thought the fight against TB was basically Ministry of Health concern. But when you look at the drivers of TB, you find that they are multifaceted. And if we are to fight or achieve this fight against TB, we had to adopt a multi-sectoral approach. And looking at the multi-sectoral accountability framework, the booklet that Dr. Enid referred to, you realize that there are lots of key players therein with different roles and responsibilities spelled for them to help us in this fight. And based on that, that's how the Office of the Prime Minister comes in to support, coordinate these different entities in this fight. So the issue of TB is basically an issue of national concern, and in this regard, very critical. On that note, by way of introduction, I wish that members should appreciate that government has an obligation to provide services to its citizens to facilitate economic growth and development. So among these services are health services. Out of the so many health services, healthcare-related services that government is supposed to be providing is also the TB. But you realize that provision of public services is an important factor that shapes perceptions of citizens on government. Therefore, service delivery is key in terms of quality. The quality of service delivery that we provide is really very critical. And you realize that over the last 5 years, you'll see that there's been improvement in how we are trying to deliver health services related to TB in terms of prevention and basically management. Our colleagues, you realize that the COVID-19 pandemic has not spared us in this fight. It looks like all service delivery points have been affected in one or another. So as we count on the achievements that we've so far made, the pandemic remains a challenge that's with us and that has affected our service delivery. The obligations of government is therefore critical in terms of delivery of quality and equitable services amid scarce resources with increasing public expectations and growing fiscal pressures. Resources are not adequate, and in this regard, we need to coordinate better to ensure that we maximize out of the limited resources. That's why you find that in our response, we are basically looking at not only government, but also non-state actors, the civil society, and the different implementing partners, the development partners, are therefore critical because resources remain scarce. Implementation of government programs, Implementation of government programs, therefore, often cuts, especially looking at the TB response or the fight against TB, is cross-cutting. When you look at the drivers, it cuts across different MDAs. And in this regard, effective coordination becomes very critical. I'll draw you to the mandate of the Office of the Prime Minister. Article 108 of the Constitution mandates the Prime Minister, that is the person, to lead government business in Parliament and coordinate implementation of government policies and programs across ministries, departments and agencies, and other public institutions. So we at the Office of the Prime Minister are basically helping the Prime Minister deliver on this mandate. And this particular function is informed or guided by way of two policy frameworks. That is the National Institutional Coordination Policy Framework, and then we also have the Policy Framework for Monitoring and Evaluation. But in this case, I'll basically dwell so much on the National Coordination Policy Framework. Why coordination? Coordination is understood as various organizations, public and private, working together to deliver a strategic goal. And when you look at the audience here, this is what we are. We are basically trying to coordinate the fight against TB, tuberculosis. It is the harmonization of implementation of policies and programs across the MDAs to ensure connectedness in government so as to deliver as one whole in an expeditious and efficient manner. So here we are with the multi-sectoral accountability framework for TB as our guiding document, whereby we are all expected to gear our efforts in regards of delivering the goal of that particular planning document. There are types of coordination, and in this regard, you realize that, unfortunately, yesterday, I happened not to be around at the time when there were issues related to the coordination function, how OPM is playing its function. But there is always a misunderstanding of OPM's function. And I think this particular slide will help us understand. Coordination is in two ways. There is intra-coordination and inter-organizational coordination. As OPM, we are basically doing the inter-organizational coordination. And the intra is happening within. What is happening under Ministry of Health, under the committee, the TB committee, is basically what we talk of as inter. So as OPM, ours is to bring the different stakeholders and draw them to a particular goal and have efforts rallied in that regard. Then the different MDAs are expected to go and do their technical mandate-related coordination. We as OPM just get issues out of there for on scaling, for further management. That is in event that there are any issues. So inter-organizational coordination is how different organizations are coordinated to undertake tasks to achieve a common goal, especially where they have some overlapping responsibilities. And the committee that the Permanent Secretary, Ministry of Health chairs is now critical in this area. The benefits of coordination are known. We have 5 of them, but basically it helps improved execution of government plans, and that way we are in position of achieving the specific development aspirations we hope to. So the National Institutional Coordination Framework is what I talked of, and as OPM, this is where we are. National institutional level coordination framework of policies, programs of government is articulated in the institutional framework for coordination of policy and program implementation, encapsulated in the coordination policy of 2015. The framework provides the overall direction for coordination of government policies and programs in service delivery using a whole of government approach. And this is what we need in the fight against TB. So that's why OPM is here and supporting the Ministry of Health and other stakeholders to take the fight ahead. And in yesterday's submissions, we had appreciations whereby the fight has been pitched to the level of political leadership, unlike elsewhere. So that is the institutional framework for coordination, whereby at the topmost we have the presidency. Like I indicated, when you look at actually even the mandate of the office of the Prime Minister is serving on instructions or supporting the presidency. Then we have the cabinet, then we have the policy coordination committee, the institutional coordination committee, and then the technical implementation coordination committee. I'm being told that my time is up. Chair.
Any slides are remaining?
I think I'm left with around 5 slides.
Okay, I give you 2 minutes.
All right.
Yeah, to go through the 5.
So that is the institutional framework for coordination of government policies and programs, and the fight against TB has adopted this particular framework. So the framework basically comprises of the Policy Coordination Committee, which is a subcommittee of cabinet of sorts, and this is chaired by the Prime Minister. And it's out of this committee that actually government approved the approach, the multi-sectoral approach, and it's out of that committee that all the different players have been engaged, the decisions of that particular committee meeting that happened in November, that all the different players are now on board. in the fight against TB. We have also the Implementation Coordination Committee, Steering Committee, which comprises of the Permanent Secretary, and this is chaired by the Head of Public Service and sits quarterly. Then the Technical Implementation Coordination Committee, which is a multi-sectoral technical committee, chaired, including the non-state actors, the development partners, civil societies, and NGOs, chaired by the PS, Office of the Prime Minister. Then we have the MDA Coordination Committee. This is where now the coordination, technical-related coordination of the fight against TB is happening. And this committee now is the Multi-Sectoral Accountability Framework Development Committee that is basically chaired by the Permanent Secretary, Ministry of Health, with technical officers from the different institutions. There we are. That's where it started. It all started under the leadership of the Right Honorable Ruhakana Rugunda, the Prime Minister then. That was in 2018. And efforts since have been on. That is a copy of the communication going out to the different entities to nominate focal persons and support the fight against, first of all, constitute the multi-sectoral accountability framework coordination committee members to rally them in terms of budgeting and planning, specifically looking at how critical joint programming is in the fight against TB. So we have at least focal persons from the different entities that sit at the Ministry of Health, whereby, like Dr. Inid indicated, the Office of the Prime Minister is also represented. We are part of the Secretariat in these meetings, whereby as our responsibility is basically to see the different issues that seem to be bringing up implementation bottlenecks for upscaling and further guidance. So looking at the multi-sectoral accountability framework for TB tuberculosis in terms of progress, in terms of key performance milestones, we're in position of establishing and steering a national high-level interministerial coordination platform. That is referring to the multi-sectoral, the fight against, we have a platform that's basically looking at TB, the fight against TB. And this was established in 2010 through a decision of the Policy Coordination Committee that was chaired by the then Right Honorable Ruhakana Rugunda, the Prime Minister. So that's one of the efforts. Then the next achievement was in regards of representation of OPM. Like I indicated, OPM is heavily represented on the Secretariat at the Ministry of Health, and all implementation-related bottlenecks are received and addressed therein or scaled up. As we speak, at least we've not had any. So Ministry of Health is really taking charge, and the attendant outputs speak for themselves. Then there was also need to provide overall guidance. Guidelines are in place. The Ministry of Health managed to come up with guidelines for that helped constitute the different committees, the guidelines, the different focal point persons in the respective MDAs have the guidelines, the TORs, and also guidelines for mainstreaming TB-related activities in terms of screening are already in place. So as OPM, we had pledged...
1 minute.
As OPM, we had pledged to have at least TB-related activities mainstreamed in the disaster-affected areas and among the refugees. And I think with these guidelines, we'll be on course. We have, that I have already spoke about it. Then as one of the key performance milestones also is what's happening now, the 4th National Stakeholders Conference that started yesterday and will be ending today. And we are looking forward to the attendant activities and outputs of these for onward implementation in the fight against tuberculosis. By way of conclusion and recommendation, we are very aware that government remains committed in the agenda, and this is indicated in the pitching of the fight at the highest political level. Then there is also need for effective sub-national level coordination. As stakeholders, we need to, like it was indicated in yesterday's presentation and the different remarks, they indicated that the fight is now taking a community approach, and this way we need heavy involvement of the structures, the coordination structures in the local government for us to really be in position of effectively implementing the different activities that relate to the fight against tuberculosis, including the parish development model, which is very key. I think looking at the community approach that is already on, that implies that actually as Ministry of Health and as stakeholders in this fight, we have actually moved, not just to, we've moved beyond the parish, we are now at household level. So Ministry of Local Government, I think in that regard, will take the fight against TB as one that has actually as one that's being delivered at household level. I submit. Thank you, Chair.
Thank you very much, Gertrude, for that elaborate presentation. I would like to recognize the arrival and the presence within us of Dr. Charles Olalo, the Director, Clinical Services. Dr. Charles, you're very welcome. Please guide me, Secretariat. Is WHO Afro here? WHO Afro and Ministry of Works? Yes, Ministry of Works, please come forward. And Secretariat, please help us to get the views of those who are online and the posts in the chat room. Yesterday, they were not given ample time. Would like to listen to their voices today. Okay, you're welcome. Minister of Works, please go ahead.
Thank you, Chairperson. Ladies and gentlemen, my name is Sewante Khalifan. I am the Principal Assistant Secretary, Minister of Works and Transport. And I have a brief presentation on tuberculosis prevention and care from a transport sector perspective. I'll try to be brief. Minister of Works and Transport is one of the ministries of the Republic of Uganda, and our vision is purely to have safe civil works, transport infrastructure and services. Our mandate, we are always looking at transport infrastructure and services. We are looking at roads, we are looking at rail, we are looking at water, air and pipeline transport, public structures, the construction industry, among others. And as a result, we have a concentration of people. Most of Ugandans use public transport, and the other citizens, we employ them in our construction business, the roads, the sites. So, Ministry of Works and Transport, of course, we have other agencies affiliated to us, UNRA, Uganda Civil Aviation Authority, Uganda Railways Corporation, and all these agencies also deal with a congregation of very many people. And the Ministry of Works and Transport was also included in the multi-sector accountability framework, where we also have to contribute to the fight against tuberculosis. And as one of the ministries identified, our role in that, our role among others is to make sure that we participate in the TB-related activities, to make sure that our campsites during those constructions, they are safe, make sure that our taxi drivers and operators, we screen them at least annually, in order to make sure that we reduce the TB transmission and spread, especially within the working environment of Ministry of Works and Transport. We are supposed to sensitize the masses against TB. We are supposed to come with regulations, especially of vehicles, on issues of overcrowding, ventilation. We are supposed to incorporate TB services with our HIV work policy, especially in those sites. And also we are supposed to come up with TB EIC materials, especially in those campsites. So, Madam Chairperson, our commitment as Minister of Works and Transport, we have commitments to especially to raise awareness on TB prevention and treatment in the public transport services. And also, we also committed ourselves to screening taxi drivers and operators annually. But as we attempt to do this, Madam Chairperson, we already have an approved work plan. A team from Ministry of Health came to Ministry of Works, and we had an engagement with top management about these commitments, and they agreed, and the work plan has already been approved. But as the focal point person, I have faced some challenges, which this congregation need to know, is that we have not had enough resources, especially for the screening, although effective next quarter, we are going to do this screening. And also we have had the issue of limited understanding of how to fight TB within the confines of Ministry of Works and Transport, especially by some members of staff. They say, yes, we are part of the multi-sectoral forum, but how do we, as Minister of Works, we still need some. I always call Dr. Ochero whenever we have a problem. I say, Doctor, come and explain to this, because they say, we are Minister of Works. Now, how do we start fighting TB? Are we Minister of Health? You are a Principal Assistant Secretary. Are you a doctor now? Are you the one going to go to this tax park and screen these people? Now, when we give you money, this money which we have, government gave us money to construct roads, to buy aeroplanes, to buy ferries. But now you are saying now we can't screen people, we treat people, yes, we can do the policy. Those we have had those challenges until when Dr. Stavi and Dr. Chero came, and then we had to explain to the PS and the minister. I say, you see, through OPM, you had these commitments. So I am a pass, but some days I can put on a white coat and be called Dr. Kalifan, and then we treat TB, then in the afternoon I go back to my finance and administration work. So at least now, Minister of Works and Transport are appreciating that you don't have to be a health worker to fight against TB. You just have to appreciate the mandate and accept the commitments and mobilize the resources. So, Madam Chairperson, resources now have been approved, and very soon you will see us on TV, or you will see us on television, in the bus park, in the taxi park, screening people against TB. Very, very soon you will be in a taxi or in a rail wagon, and you will see an IC material. Or when you are looking at our construction sites, those signposts which we put for construction of roads will no longer be putting those words of HIV only, but also some sentence on TB will be highlighted, because the management has agreed as part of the solution to the challenges we are facing. Because when Dr. Chero came and through the guidance with Dr. Stavia, we tried to create awareness and amongst the senior management to say, you people, this is a very serious problem, TB. Because I remember Dr. Chero saying, you see, TB is not a problem until you have it or until someone you know catches it. That's when you would appreciate. And when they said now, for instance, all of these people, because we have a lot of contract staff in those regional workshops, and even our construction, so he said, okay, let us go, let us. Now, so he said, where are we going to start screening? He said, no, we are going to have health workers, we have ever done this work. So the solutions are there now. The screening is set. The ESC materials, they are already in procurement. As I told you, we signed the Form 5 and they are being procured. And also the committees there, headed by me. And those interventions and the commitments, we can assure this conference that next time when we come here, we will be giving an update on the implementation of the commitments made by Minister of Works and Transport. Thank you so much. I beg to submit.
Thank you very much, our colleague from Ministry of Works, for that update. The outputs were very clear, and your challenges well articulated. I hope the Secretariat has taken note. I've been informed that WHO Afro is not here. They are neither online. So we shall skip that presentation. But briefly, to take you through the targets and commitments that WHO was supposed to appraise us on. Those of you who have the booklet for the multi-sectoral accountability framework for TB, you realize that we have global, national targets and commitments related to the SDG goal, and the target is 3.3 to end TB. I don't know what 3.3 means. Then WHO's strategy, NTB strategy, that was adopted in 2014, and associated World Health Assembly resolutions of 20, and the targets that were set for 2030, 2035. Then the Moscow Declaration. I think these are the instruments that will lead us to ending TB, the ones I'm reading. Then the Political Declaration of the United Nations General Assembly High-Level Meeting on Tuberculosis in 2018 that we alluded to yesterday, where Uganda was represented by the Prime Minister, the former Prime Minister, Honorable Ruhakana Rugunda, and the Minister for Health, Honorable General Thacheng, and technical officers from the ministry. And they did make commitments at this high-level meeting, and it is against that background that as a country we came up with a multi-sectoral accountability framework for tuberculosis so that we are able to meet those commitments and targets. Treating 4 million people, that is a global one. For TB, because the country, Uganda as a country, we are 40 million. So 40 is a global target. And the National Development Plan, the National Health Development Strategy, and the Strategic Plan for TB has the target for us as a country. Mobilizing, reaching at least 30 million people with TB, preventive services, preventive and treatment services within the strategic plan period, and also mobilizing resources to the tune of 13 billion annually for universal access to TB diagnosis. Yesterday we heard about the catastrophic expenditure, and we looked at the cost drivers, the patients making multiple attempts to access services and the frequent visits to the healthcare facilities because the treatment is rather long compared to other diseases. And also the monies they spend on feeding. And I would really like to stress that the parish model, parish development model, one of the pillars is agro-industrialization. And here we are looking at households being able to produce enough for feeding, meaning that the TB patients will also feed well and also have surplus for sale. And when they feed well and adhere to their treatment, they'll be healthy and productive, and thus contributing to national development. Mobilization of resources, 2.5 billion annually. And I want to state here categorically that we should not focus on resources. Let us focus on the ideas. When you get the ideas right, you realize that actually these resources that have become a song, the inadequacy, are not even necessary. Let me have questions, additions, comments, and then we move to the next session. I hope you've been taking down your questions and comments. Let's have the hands up. Also from the online participants, Secretariat, please identify them and let them ask their questions. Yes, I see 2 hands. On the right-hand side, we can start with the front, with the 4th row. Yes, yes, sir. Where is the mic? We seem not to have the mic. You can quickly come to the podium. No, we shall allow them to ask questions. We shall allow them. Okay. Okay, quickly move to the mic. I think the next question you should also, let's line up behind him. Those of you who would like to ask questions, social distance, and line behind the mic.
So how are we going to utilize that? And the other one is about screening bus drivers and operators. I wanted to learn a little bit on how you are going to enforce, because this is a really big problem, given that most people spend a lot of time in transportation. and compliance with the safety measures like ensuring that maybe there is good aeration is quite a big challenge. So I wanted to know the strategies you have for that. Then the presenter from OPM, thank you so much. I wanted to see how the private sector, the private providers, especially the hospitals, private hospitals, how they are going to also to be part of this coordination mechanism, because we realize that many people get services from there, and we need to coordinate with them. Thank you very much.
Those who have questions, kindly line up behind the mic to save time.
Thank you, Madam Chair. My name is Kankwasa Johnson, ADHO Shema. It is an addition to one question of my colleague about how you are going to handle the screening of bus park people and the tax park. I just wanted to remind you that let you not concentrate on the Kampala bus parks. Just move up to our upcountry bus parks and tax parks. Thank you.
Good morning, ladies and gentlemen. My comment will rather go to the Ministry of Works. We understand the challenges as you've posed them, but I think OPM deserves to do much better in trying to coordinate the various ministries in this aspect. What they have done is good, but I think more of the practical part of it, whereby they can task the ministries to commit a certain percentage of their funds to this fight. Why? From Wakiso district, and I've not seen you mention about the boda sector, and yet the boda sector, we know very well that they are at risk when it comes to HIV/AIDS, when it comes to COVID-19, when it comes to TB. I don't know what plans you have for these bodas, because the stages are really so many, and many people in those roads that are not yet developed well in the rural sectors opt to use bodas to a large extent, and they go communicating. And we also find that they are in level 1 of the promiscuous sector. So when you add all those facts, how are you going to coordinate with the decentralization or with other political leaders and the community to make sure that they actually get part of your IEC materials, at the same time screening, and also, I think more so, the contact screening. Thank you very much.
Thank you. Once again, I'm called Egwal Moses, and I want to appreciate the effort of this conference. I think this time around, the image is going to change when we go back. And I want also to appreciate how COVID, in fact, right from our president, the president of Uganda, his team, the ministers, and all stakeholders that played a key role in fight against COVID. And in that regard, I still encourage people who are not vaccinated to go for vaccination. But I love the response that was given when it came to COVID-19. COVID-19 is just a baby of 2019. TB has been there for a long time, but the response always a bit slow. But I do appreciate this conference, because if we really lobby funds, that will enable to build the capacity of what health workers, right from the grassroots, VHTs, cough monitors, health workers, then also our political leaders. Our political leaders also have a role to play, and I remember yesterday, Banarabi said that he doesn't know where to get these reports. But the truth is, these reports are everywhere. They are in health center, district level. They are even on media, reflecting how TB is a burden. So, in that regard, my question goes to the former presenter. How are you going to help us? Me, I work in a position of a DTLS, but in most cases, you only get soft copy. No hard copies are given. Like, I'm supposed to go out for support supervision. You cannot even have that coupon for what? For maybe.
Is your question? Summarize? Yes.
As a DTLS at a district level, we are not actually given enough support to carry team activities. Resources are limited, I know, but whenever we are given just way to go for supportive supervision, I think it will improve a lot. So
Okay, point noted.
Then the other one, IPs. I have to thank you, you play a big role. But the IPs are not equally distributed. Some regions, you find there are so many IPs, some regions there are few. And I don't know why they are not equally distributed. Then the other one is, we need teamwork. Let's work as a team, let's fight against this mosaic, TB and LEPROSY, the way we handle COVID-19. Thank you so much.
Thank you. Do we still have any hands up? Please come forward. I would like to read the questions that we have captured in our chat. One, Dr. Eric Obdeya is requesting Mr. Sewante to provide at least 2 practical examples of how they will conduct mass sensitization in concrete terms. 2, members, this one, a call area, is posing a question to all of us and is asking what is the way forward for very many people or patients who are not able to reach the health center. That is a call. And then there's this one from Innocent Twebaze, that these actions by the Minister of Works are extremely helpful, and he thanks the pass from Ministry of Works, and he would like to urge all other ministries to move in the same direction. Achievements of the unrealistic targets can be possible, meaning they are not realistic. And I would like to clarify on this question that we did a roll call, and you realize that there are quite a number of MDAs that have a stake in this, although some were not given an opportunity to talk about what they have done. So they are on board. I'm sure all of them have the education materials in the taxis and bus windows, bus park, materials distributed through the windows. And the sooner you do this, the earlier you do this, the better. Then there's another one from Mbale Regional Referral Hospital, medical social worker, thanking Mr. Sewante for the good presentation And his humble request is that if Ministry of Works screens cyclists because they have diagnosed many and treated them. And therefore, it's an indicator that they're a high-risk group. So, sir, consider the cyclists as a presenter has said. Secretariat, if there are hands online, let's have them and then we answer the questions at once. The hands online. Okay, thank you very much. So let's have answers.
Thank you, Madam Chair. I think members need to appreciate that whatever we are going to do as Minister of Works and Transport comes from our commitments we made to the Office of the Prime Minister and government, what we are supposed to do as a contribution to this fight against TB. And those commitments is to raise awareness on TB prevention and treatment in public transport spaces. Those are the bus park, the taxi park, then within the taxis, and also to raise the profile of TB prevention among the mobile populations, including the construction, especially those construction sites, and the screening. So how are we doing the screening? Of course, these questions also had them. That's why I said those are the first problems we got when the OPM wrote to us saying, hey, Minister of Works and Transport, TB now is a national problem and we are doing it together. It's no longer Minister of Health alone. Now, when we got these challenges, of course, we had to call Dr. Chero and Dr. Stavia to come and explain this. And now, how are we doing it? Minister of Works and Transport, we are basically giving an enabling environment, coordinating, but the actual screening, it's not the civil engineer or the administrative officer who is going to go to the bus park and screen. We are using Ministry of Health structures, both officers from Ministry of Health and the hospitals and the clinics. So like when we go to, unfortunately, the other question of the nationwide screening, we are starting with Kampala, the main bus park and the taxi park. So for us, we'll provide the resources, provide the enabling environment and the mobilization of those leaders. Then the actual screening will be done by the health officials, and those that are positive, I'm sure they will be referred to those health facilities. So basically the actual work is done by Minister of Health, but the supervisor, the coordinator, the facilitator is Minister of Works. Then the EIC materials, our target mainly by January, February, we are looking at the rail transport, those Kayora things, because most of the people in Kampala go to URC to board. So we are looking at the rail transport, and then we are also looking at the buses. That is where we are concentrating by putting those sensitization, those EIC materials. But generally speaking, we're also now looking at sensitizing our workers when we are constructing roads. Those people look at those signposts which we put, that we are constructing a road sponsored by this, financed by this. Then down the results, we are always looking at environment and looking at HIV. But now we are telling our contractors that they have to mainstream TB and highlight it for people to appreciate that it is a very big problem and it needs to be given attention. So in practical terms, sensitizing, we are looking at, apart from the transport sector, where the public, we will meet the public in the buses and the taxis, but also we look at our own contract staff, the people we hire to do our roads, to do our rail, to do our ferries. That one, we are going to do it by ourselves, especially by use of our agencies. We are in touch with the Uganda Railways Corporation for them to say that now we are doing this. We are in touch with UNRA when they are constructing those roads, also to emphasize it. And the PS has written to these executive directors, and they have responded saying it's welcome, bring the materials, and we distribute them. Then after Kampala, later we'll go to these other regional centers, and then we will progress as we get the funding and as time goes by. Thank you so much.
That's that the ministry has a rollout plan, starting with Kampala. It's going to be phased. Questions for Gertrude? Quickly. 1 minute.
Thank you very much, Chair. I had a question from Dr. Pande Stephen, who was concerned about involvement, coordination of the private sector players. How are we as OPM coordinating this particular group? This particular group, first of all, is being coordinated under Ministry of Health, specifically under the multi-sector accountability framework technical committee that's chaired by the PS Ministry of Health. We expect their representation there, and they are being coordinated there technically. Then, in event of any issues, they can still further be coordinated at the Technical Implementation Coordination Committee, chaired by the Permanent Secretary Office of the Prime Minister, where Ministry of Health is represented. So all those stakeholders, issues and concerns are really being catered for under the flagship of Ministry of Health. I submit. Then there was also a question on committing. How do we get the different players to commit to fund the fight? It's good the representative from Ministry of Works indicated that the commitment is on high, and whatever they are doing actually arose out of coordinated efforts from the Office of the Prime Minister, and it's out of this communication. Of course, communications went out to very many, but it's unfortunate that it's only Ministry of Works that is representing, but we believe efforts are underway, and all MDAs, implementing MDAs, are actually on board in the fight against tuberculosis. It's only that we've only heard from Ministry of Health, but the commitment is on, and there is mainstreaming of TB ongoing in entities programming and budgeting. I submit.
Okay, thank you very much, Trude. Thank you, Mr. Our colleague from the Ministry of Works. Thank you for those who have asked questions. Just to emphasize that we are moving away from the sector-led programming, implementation, budgeting, to the program working, to the program implementation, planning, and review strategy in NDP3. And as we plan for the next review, we'll be looking at that approach, not looking at individual sectors working in silos, but working as part of the program. For instance, we know that health, education, gender, and water are under the human development, the human capital development working group, and therefore that is how we are going to handle the reviews moving forward. There's a letter that came out from the ministry, from the PS Office of the Prime Minister, requesting those program working groups to integrate their actions and work plans into the program implementation action plans. And I guess it was done. So next time we are taking stock, I really urge the organizers, the secretariats, to make sure that whatever we do is within the context of the National Development Plan 3. And lastly, on the issue of multi-sector approach, I'll still refer you to the multi-sector accountability framework for TB, where the sectors and agencies that have a big stake are highlighted and the roles are clearly stipulated. The private sector being one of them, the academia, the community leaders, political, at all levels, cultural, religious, their work is clearly stipulated. So if there's an issue with the dissemination of this framework, let us know. But it is a must access for each and everyone if we are to meet our targets and commitments. And lastly, Gertrude highlighted the coordination structures. We need to activate them. They need to do some work. We need to see the high-level mechanism chaired by the Prime Minister doing work. And we need to clearly capture the issues that we shall escalate to that level of coordination. At what point during the conference, I'm not very sure, but they cannot sit without business. So thank you very much for giving me an opportunity to steer this session, and I really look forward to us meeting the targets. Let's be positive, let's not be pessimistic. TB can be eliminated. Let's take COVID. It's a challenge. We take it as an opportunity, as was proposed yesterday. And we defeat this TB thing. Thank you very much.
Yes, thank you very much. Ladies and gentlemen, we add them an applause. And at this moment, I want to take this. Don't be limited by this. Let's go in for ideas. That's what I heard from the chair. The chair of this session has told us, let's not get limited or bogged down by resources. Resources are not coming. But where are the ideas that we want to implement, then we can look for the resources. Here is how we are going to proceed. We are going to adjourn for a break tea, and we should be back here by 10 minutes to midday. Yes. Look at your watch. What's the time? You want a working tea? There is a proposal that we handle a working tea, that those at the back will start by picking their cup as they come in, and that implies the discipline. We shouldn't go to congest behind there. Then that implies that I now invite Dr. Olaro Charles, Director Clinical Services, to come and take on chairing the next session. And that implies Dr. Eleo Wandwalo, get nearer, Professor Joseph Joloba, Mr. Muzamir Bamulonda, Dr. Eldo Barua, and Dr. Rose Kengonzi should also be getting nearer, for you have to present make your presentations. So those I've mentioned, come and take your seats, and the chair is already with us. Chair, you're welcome. Chair, over to you.
Thank you. But I'm seeing the room is getting empty, so I don't know whether we really took the initiative that a few at a time go out, but we have to get started. I think we are going to allocate the next session 1 hour, which means that we'll have the presentations for 10 minutes. And I would want to get to know where the first presenter is in the room or is presenting online. So we are going to make some modifications so that I take note of the professors, the presenters there's a professor, there's a community specialist, there's an advisor, there's a technical officer, and I know that we would want that you tell us really what's important to hear, and you leave out what is good to hear, and so that we really do a catch-up. So I would want to invite the Eled Wandoli from the Global Fund, or his representative, to take us through the 2 year of COVID pandemic, reaching people with TB, and the global updates. The sub-theme for this next session is continuing the TB services during the COVID-19 pandemic. And I would, at the same time, ask Professor Moses to move up front so that if I could have all the presenters with me here so that we move smoothly for the next, through this session. So, Dr. Elliot, you're welcome to make your presentation. The online team, can you be able to manage the digital team?
Hello, can you hear me now?
We are able to hear you. Yes.
Thank you very much. My name is Eliud Wandwalo. I'm the head of the tuberculosis here at the Global Fund in Geneva. And I would like to take this opportunity to thank the National TB Program for inviting me to this important meeting. I don't know if someone is putting my presentation there. I have a small presentation which I've shared. Yeah, so it's there. Yes, thanks. So I'm going to go very quickly into this presentation. I know I have less than 10 minutes, and in the interest of time, I'll skip some slides. So can we go to the next slide? And go to the next. So I've been asked to give an update on the TB situation 2 years into the pandemic. And I think I would like to start with this slide. This is the slide which I presented.
No, with the masks now, it's very difficult.
Hello, can you hear me? Can you hear me?
Yes, we can hear you. Go ahead.
Yeah, good. Good, thank you. So this is the slide which I presented last year. And if you look at this slide, try to compare tuberculosis and COVID. And last year, when I presented this to this meeting, by then COVID had killed about 1.4 million, which was the same as tuberculosis. But this year, COVID has surpassed tuberculosis as the #1 infectious killer, with about 5.2 million people died from this disease. And of course, you can see a lot of overlap between COVID and tuberculosis in terms of the mode of transmission, even the way we respond to this disease. But what is so striking from this slide is on the innovation on the diagnostic, vaccine, and also funding. So you cannot even compare these two diseases, although they have a lot of similarity. Last year, when I presented in terms of the diagnostic, there were less than 1,000 diagnostic which were on pipeline. Now, the diagnostic are more than that. Last year, we didn't have any drug, even in the pipeline for COVID. So now, at least, we have drugs which have already been approved by regulatory authority. We know Munapiravir, for example, the one from Merck, has already been approved in a number of countries. But for TB, in the last 2 years, in the last 40 years, we only have 2 new drugs which have been developed. So you can contrast and see. In terms of the vaccine, we don't have any potent, good vaccine for TB. We have, of course, M72, which is in pipeline, and we don't expect to have it maybe for the next 8 years, if we are lucky. For COVID, last year when I presented, there wasn't any vaccine which had already approved, but now we have 8 vaccines which have already been approved by WHO and also they are in use, and a number of them in pipeline and also in different stages of clinical trials. In terms of the funding, last year, TB, we had more than 6 billion for TB programming in low and middle income countries. This year it has dropped. If you look at WHO report for 2020 to about 5.3. And for COVID, everyone know, we don't know even the numbers in terms of trillions, which is available for this epidemic. Can we go to the next? So this is the situation of tuberculosis globally. WHO released its report in September, which shows there was an 18% drop in TB notification in 2020 compared to 2019. As Global Fund, we released our annual report, which shows the same, a drop of about 18% in the countries we are supporting. If you look at the number of people missing from treatment, we call missing people with TB, that number has increased to 4.9 million in 2020 from less than 3 million. And we were making a lot of progress in this front. Actually, in the last 3 years, we were really getting more people missing with TB, putting them in treatment, but all this progress has been put back by COVID. Next. So this is some of the graphs from different countries, and I think the most important thing to note there was a big dip in most countries. We are seeing a sign of recovery, but it's too early to show. But generally, if you look at the epidemic, I think Africa was not so much impacted in terms of the TB notification compared to other countries, especially Asia, where we see a big impact in most of those countries. Next. A few countries where we have a lot of concern, as I said, in Asia, you can see there Indonesia, the second high burden countries where we have not seen recovery, numbers are still going down, Philippines in the same, and other countries. So we are still not out of the woods, but I think we are seeing a sign of recovery in most countries. Next. So these are the results from the Global Fund. We are tracking results, of course, in every country, but we have 20 countries. These are high priority countries, which have about 83% of all TB burden supported by the Global Fund. And as you can see, the performance of these countries vis-a-vis their Global Fund targets has improved a little bit in 2021 compared to 2020. Where overall performance of these countries was about 81% in first semester of 2021 compared to 63% in 2020. But I want you to pay attention to the countries there. You can see 8 countries have been able to reach more than 80% of their target, and Uganda is one of those countries. And in fact, Uganda for this semester, they've actually surpassed their target for the Global Fund compared to the progress of the implementation. And at this juncture, I would really like to thank the National TB Program in Uganda. Uganda is one of our star countries when it comes to tuberculosis at the Global Fund. We have seen tremendous achievement in the last 3 years, I would say. In Uganda, I know the country has been struggling a lot before in terms of the TB indicators, but we have seen a big shift in the last 3 years. And it's one of the countries where we are proud as a Global Fund in terms of what we are seeing the results. And this is because of the strong leadership from Dr. Stavia, the NTP manager, and her colleagues there, the Minister of Health, and of course, also support from our country team. So I would like to note that one, and we are very proud of our collaboration with Uganda in terms of what we are seeing happening. Next. Yeah, so just very briefly about our support to COVID. As you know, Global Fund has been supporting countries right after the epidemic started last year. We made available about 1 billion to support low and middle income countries in 2020. And this year, around March, April, we made available around 3.7 billion US dollar support countries to respond to the COVID, to mitigate the impact of COVID on TB, HIV, malaria, but also to help with the urgent community and health system. And at the moment, Global Fund is the largest supporter of countries for anything COVID apart from vaccine in middle and low income countries. Up to November 26, we had already made the recommendation to our board for approval of about 3.1 billion. We had a big request from countries about 4 billion, and this money is now being disbursed to the country to support with critical COVID mitigation, to support with the medical oxygen, diagnostic, and anything related to PPE and anything related to the COVID to most of this country. Next. Yeah, so in terms of the support to the COVID, about 75% of this support is to reinforce urgent COVID national response. About 14% of the money is urgent improvement of health and community system, and about 10% is to mitigate the impact of COVID on HIV, TB, and malaria. Next. So on the mitigation aspect, about 33% of it went for TB mitigation, which is more than 100 million, 38% for HIV, and 29% for malaria. Next. Yeah, maybe I'll skip this one. Can we go to the next one? Yeah, so one of the issues which we have observed when we reviewed the funding request for COVID, a lot of countries have put mitigation measures for TB. And one of the most common mitigation is what we call bidirectional screening for COVID and TB. Basically, it's integrated screening and testing for COVID and TB. And we did a review, and we have seen about 40 countries out of 100 which have submitted and put that mitigation, which is about 21 million, including Uganda, where you have this activity. But one of the issues we have observed, although this activity is there, but there was very little information in terms of how this activity will be operationalized. And this is an issue which we have seen across COVID, TB mitigation activities. I think countries are still slowly taking up this intervention. And what we think from Global Fund, I think we need to accelerate the operationalization of this intervention because time is not with us. The COVID will continue to be with us for some time. And we need to be a little bit aggressive in terms of rolling out this intervention. And this is a challenge we are seeing across the countries. Next. So very briefly about some of the examples we know, for example. So one of the countries which has really been able to implement this bidirectional screening or integrated screening for TB and COVID is very clear that it's India. And they did that since last year, and they shared the results with us. For example, in this slide, we show that they screened about 500,000 COVID patients for TB, and they've been able to get a relatively good yield from that. So I think the number of the patients who they've been able to notify that screen and be able to diagnose out of the COVID was about more than 380 per 100,000, which is 3 times compared to the general population. So the yield is good, but it needs to be targeted. But if you extend that screening not only to COVID patients, but also anyone with influenza-like illness or severe acute respiratory illness, you will see that the yield is increasing. So if you extend that screening to that group, the yield increased by 7-fold. So I think the message here is that we need to be more aggressive when we do screening among COVID patients for TB, but also any other person with respiratory tract infection. We need to be targeted in terms of the screening, but I think we need to do that. There's no way we'll be able to catch up if we are not be able to scale up screening and diagnosis of TB. Next. So probably this will be my last slide. So I think in conclusion, based on our analysis of the countries we are supporting, we have seen that countries generally have very good plans of mitigation through their current grant support, but also through C19RM. I think the biggest issue which we have seen is not the plan, it's really the speed of implementation and the how part. So the what is available, but the how and the speed of implementation, that's the biggest limitation at the moment. We have seen countries establish mechanisms to rapidly monitor the impact of COVID on tuberculosis, and I know in Uganda you've also established very quick mechanism. You don't wait for 3 months to get all the reports, because as we know, the epidemic is changing very rapidly. In fact, now for COVID, if you want to know even what happened, in few hours, you go into internet, you will be able to get that. And TB program also need to move that fast. We need to have really information, real-time information to know how we can respond and how we can change to the ever-changing situation. We have seen generally many countries have started with very slow implementation of their grant, but also with the C19 interventions. And in many countries, because they use the normal system, they are not that aggressive. I think they are likely to have a longer delay into implementation of this COVID-related activity. Human resource has been cited as one of the key challenges in many countries because many of the TB staff were really taken to the COVID, but also this newer intervention such as bidirectional screening, integrating COVID with TB would require a little bit more human resource. So this is one area where we have seen a challenge. I think one of the issues we have learned across the countries, when countries try to implement most of their activity through community-based activity, most of the programs, they are very resilient. If you just rely on only health facilities, and especially public health facility, once there's lockdown and also other COVID measures, then this tends to really affect the program. So the message here really expand your services, go to the community, integrate a lot of your intervention. Look at the private sector. Look at all avenue which you can be able to implement despite there being COVID. And also with the drug-resistant tuberculosis, we have seen where the DRTB has been decentralized, they've quickly moved to the oral regimen. The impact has been less compared to where they really rely on hospitalization and also health facility. We see COVID, although it has really impacted the TB program, but there's a lot of opportunity to leverage resources which are available and platforms which are being built for COVID, which could really also help tuberculosis. And this is untapped opportunity which we really need to think how we can use those opportunity platform resources and attention which is in COVID also to help with tuberculosis. Bidirectional screening or integrated screening and testing has been requested by many countries, but I think many countries, they are very slow into implementation of this part of the intervention. And us as a Global Fund with partners, we are ready to work with Uganda, with partners at the country level to help you to be able to quickly scale up these newer interventions, which are part of the COVID-related intervention, and be able to scale up programs so that we should be able to reach our targets. So I'll stop there, and I'll be happy to take your questions and comments. Thanks.
Thank you very much, Eliud, for the presentation. And again, I would want the members really to upload the National TV and Leprosy program, because you heard from none other than the Global Fund on our performance. And I think at the same time we ask if there are aspects which we definitely will need more money. Global Fund will really be able to work with us to see how it's supposed to even it much more better. And I'm sure it will even perform much better when now we get the multi-sectoral accountability framework. You heard from Minister of Works, if we can get all the other sectors working together, we are really looking forward to see these results. Our next presentation is going to be presented by representative of Professor Joloba, Mr. Manyango Charles, and please, Charles, my namesake, take 10 minutes and make your presentation.
Good afternoon. I'm called Charles Manyonge, and I'm here to present the challenges and successes in terms of TB diagnostics, especially in the pandemic situation that we are facing. Okay. So, as you can see in this slide, we are just looking at the estimates of the TB burden. By 2019, you could see that the MDR numbers were quite high, and you can see the progression of mortality rates among the HIV negative patients actually are going down, and this is in correlation with what the WHO has just presented. Our graph is actually quite different when you compare it with other African countries. When you look at the laboratory capacity, currently we have close to 1,666 TB treatment units, and we have 296 machines, and these are within 271 TB treatment units. And when you look at the capacity to handle diagnostics, we are actually on top of our game as Uganda to ensure that the end TB strategy objectives and aims are met. You could see that we are able to perform all the tests that WHO has recommended, including sequencing. Uganda is the only country which has the capacity to do sequencing for TB, especially for discordant genotypic and culture TB, and we are using this for quality assurance of other countries who are doing drug-resistant survey. I'll go ahead and talk about the capacity at NTRL. We are able to do different tests as far as TB is concerned, and this involves even the new tests which are in red, sequencing, the TrueNat assay which is being piloted, and also we have supported the COVID pandemic issue, especially when it comes to quality assurance. We have taken lead in ensuring that we prepare proficiency testing panels for SARS-CoV-19 as well as the TB LAM. I think from my predecessor's presentation, Uganda is really taking lead in all aspects, even including diagnostics. And I think that's why Uganda is designated as an SRL in the region. And this is because of the leadership that has been exhibited within the Ministry of Health and within the program. Currently, as we stand, we didn't have TB LAM across Africa, but we have started piloting the proficiency testing for TB LAM, which we are doing in country, and then later on other countries will benefit from this. When it comes to human resource, We have quite an array of human resource with different capabilities and technical competence. And these streams right from the support from the NTP and Ministry of Health, who have been instrumental in supporting the network. Maybe I should say that in this meeting, most of the time, people lament or complain. But for us who have visited other countries, actually, we see how far we've gone. And you will see that countries now come to Uganda for benchmarking. Countries come to Uganda to benchmark on our TB network. They come to benchmark on our practices that we have put in place to ensure that patients really are enrolled on treatment. And also, our network, to say, is very strong in involving patients in terms of diagnostics and also initiating them on treatment. And now with the advent of COVID-19, I think the best way to go is integration, as we've seen the presentation from the Indian status. Integration is the way to go, and the program actually has taken this up, where we are using now our Gene Expert platforms also to carry out diagnostics or screening for COVID-19. However, since the beginning of the pandemic, initially our take-up of these, utilization of these machines have been good before, but when the pandemic set in, we started having competition. So, because it was a national program, some machines had to be taken to sites of screening, and these are hampered screening of TB, and we had to go back and use our integrated specimen referral system. So in this slide, you can see the utilization of Gene Expert per region. You realize that in Lango, Bunyoro, and Karamoja regions, there has been a tremendous uptake of these utilization of these machines. And also, in addition to that, when you look at bacteriological confirmation, you realize that NTRL plays a role in ensuring that patients who are on treatment, especially MDR treatment, they are monitored using the culture and DST approach. And I would like to commend the program for this, because they have actually made NTRL, which is the technical arm of the program, to give updates as far as MDR patients are concerned. And this has become actually one of the indicators for NTRL to be reporting on the status of the MDR patients. And we are using now the existing platform, which is the platform where we are able to know how many rifampicin-resistant cases have been diagnosed within the network. And out of that, how many actually have sent their samples for culture and DST. I've talked about this. However, all African countries have similar problems, whether the pandemic is there or not. Okay? In terms of human resource, in terms of infrastructure, in terms of quality assurance, access, biosafety, financial matters, and at the end of the day, pandemic. Pandemic is something that in all our strategic plans, we had not factored it in, but the next strategy is to have this component put in it so that we don't get affected. So with the introduction of the COVID-19 testing using the Gene Expert, we realized that we needed to have a comprehensive plan to see how we can integrate these two activities together. And this actually has been done tremendously at the regional referral hospitals. And as I'm speaking right now, we've had now a pickup. Initially, people had to go and concentrate more on COVID testing, But because of sensitization, support supervision, communication, and also mentorship, right from the top management, now people are able now to do both COVID and TB diagnostic. This slide talks about the situation of COVID-19 in Uganda. I will say that most of the machines which are being utilized for COVID testing, they're actually TB machines, okay? But because of integration, I think national program wants integration to happen so that both the TB and COVID patients can benefit from this. However, integration has challenges, and one of the challenges is human resource constraints. So when you have a human resource who is supposed to do TB and who is supposed to do COVID, you'll realize that there will be some competing components which need to be streamlined, and also inadequate M&E system and technical capacity to support the integration. When you look at the impact of COVID-19 on GeneXpert, the first lockdown, we really had a shift in terms of diagnosis, but we had now to come back on the board and see how are we going to ensure that actually people are screened for TB. And as you can see, for the last 2 quarters, the numbers are going up again, and this is in line with what WHO is actually giving us, which is quite tremendous. And this, I think, has been as a result of support supervision, and also I heard of a bottom-up implementation system, which has been quite instrumental. And also the case notification rates, you can see they are quite going up. When it comes to challenges, you realize that only 16% of the 1,666 DTUs have GeneXpert machine. And hence, this will result in delay of results. It is a good thing to actually expand this to around 50%, because using the integrated specimen referral system to send samples to the GeneXpert site rather than procuring the machine, it's quite costly. So it's better we actually increase or scale up the procurement of these GeneXpert to these DTUs. If we can have 50% of them, then we shall have actually case notifications increased. What can I say about the lesson learned? I'll beg just to have 4 minutes of this presentation. This is the gist of what I wanted us to have in mind. We've had some good lessons, and the good lesson is more investments in diagnostics is needed. We need to buy more GeneXpert machines, and also at the national level, if possible, we should have infinity machines. Then at the regional level and the health center levels, and also some health center 3s which have high volume TB patients, they need to have these machines. And then also we embrace the use of the data connectivity. I want to say that we are actually moving very fast when it comes to data connectivity solution using the laboratory information system to report both the MDR patients on treatment and also to report the GeneXpert results from the site to the national program. And also there is need to integrate the specimen referral, which is quite instrumental. However, reassignment of GeneXpert platform and human resource needs to be looked into. We need to sit down and see how we are going to balance the boat so that both TB and HIV, and COVID can be, results can be realized. Bottom line is the HR resilience has been there despite the pandemic. This has resulted to death, but we have to cope up with the situation. As we've heard, COVID is not going anywhere. We need actually to do more. One thing is that we need to restructure our national strategic plan to involve these investments that we are planning to put in place. And also need to optimize the integrated diagnostic network. We also need to invest on rapid diagnostics. I think this is what is happening right now when it comes to COVID. And also acquiring more high throughput platforms. I've talked about this. And also looking at the connectivity solution, timely reporting. I liked the issue of direct observation therapy, but using the electronic system, which is quite good. However, I should also say that NTRL is also a supranational reference lab, which has also had achievements. We've enrolled more labs on EQA and also on supporting them on culture and sensitivity. And the bottom line, we've also given birth to other SRLs. So we have Rwanda and Mozambique under the leadership of SRL Uganda. And this has been instrumental because of the program. I think our program manager has a certain quality. She gives you a challenge to do more, which is quite impressive. It has helped us to move a milestone. With that, I say thank you very much.
A big hand clap for Charles. So he has just spoken like Professor Joloba. You have not been able to miss Professor. I think it's really a lot of capacitation taking place in this area. Our next presenter will be we'll listen to a bit of the community aspect, finding more TV in the community during the COVID response lessons. But also when I came in and took over the office, I want us to recognize and clap for one of the TB and leprosy champion, Kuruhira Godfrey Ekao Buikwe, seated just on my right. So I think we'll be able to work with us to see that we address the issues of TB in Buikwe and anywhere where service will be deployed. So let me invite Musa Miru to take us through this. And he said, though the community is large, but he has promised to make a summarized presentation. You have 10 minutes to make your presentation.
Thank you, Chair. And I commit that will be within the 10 minutes to summarize what happens in the community. But as we know that our TB patients stay within the community, and therefore community forms a key aspect in this endeavor. Good afternoon, members. As you would see on the screen, we are saying the Cast TB campaign. As you would see there, from the talks of yesterday, we want to cast TB. And in the process of casting TB, we need to end TB and leprosy in Uganda. Therefore, if we have to do this, we need to see that we find those TB and leprosy cases that are within the community, probably during this hard time of the COVID era, and even the times to come. This side, right, is interesting. Who is handling this? Okay. So, as I had initially mentioned, that we need to move to the community, but the question is, why do we need to move to the community if we are really going to handle the issue of TB and leprosy? One, you would look at the statistics that are being projected up there. They are actually giving us what is it that is the problem within the community. One, we are seeing more people missing with the TB within the communities. So if we're actually seeing more people missing within the communities, just within a time lag between January to December 2020, you see over 10,000 people missing with the TB within the community. In the same trend, between January to June 2021, where we are seeing another additional 3,646 people missing with the TB, and they are within the community. But at the same way, the most funny part is there are those that probably have even reached the facility, and we are losing them through the line of treatment, and they are continuously also staying in the community. But nevertheless, we need to understand that not everyone that has TB within the community will come to your health facility, where we always wait for them to come. We look at them, we screen, we test, and probably if they are positive, then we initiate them onto treatment. Therefore, looking at this slide alone, you can judge the magnitude of the problem that we have in relation to TB and leprosy within the community. If all these individuals are within the community with the disease and they are spreading, imagine what next. Therefore, we know as government and the partners, we have undertaken a number of interventions. And these interventions are trying to avert the situation. One of them is we have been doing the home-to-home visitations. We know we've supported them either by the partners or by the government, as it has been mentioned earlier. But still, the slide one presentation gives us a picture that people are missing there. We have done the mobile clinics. We have actually done the community outreaches. We've even gone a level that we even agree with the patient to deliver the drugs to a neutral position or even to their homes to see that they can actually continue with treatment. But even after doing all this, the problem of TB and leprosy still continues. So the question goes to us, what is it that we are not doing rightly? Because by now, we would have actually sorted this. You saw yesterday when one of the presenters was saying that our targets are not actually near to be met. So it is something that we need to think. We don't need to think that TB is within the facilities, but we need to find a way to reach out to the communities. Therefore, with those interventions, what have we achieved? One, the Minister of Health undertook a campaign in May 2021 where they were able to engage 50 districts in Uganda in a campaign mode and within 4 days. Within the 4 days, they were able to engage the 50 districts, covering the VHTs and the health workers from that end. In totality, you would see that during that period in May, we were able to reach to 8.3 million people with the TB and leprosy messages. So out of that, you would see in the shaded part of it that we were able to screen over 100, and that is 25 or 35 people, of which we were able to diagnose 1,578 with TB. Therefore, if in 4 days we were able to diagnose 1,578, if we made the campaign mode a routine intervention, won't we be able to find all the missing TB and leprosy cases within the communities? However, the challenge at this point is we were able to get 1,500, but out of the 1,500, we only initiated 1,200 onto treatment. Therefore, with the partners who are here, still there is an issue. Even those that we were able to detect, we have actually missed some at the point of even after detection. Therefore, we need to think of a mechanism that can strengthen this to happen. In the same way, we look at working with the partners. This is an intervention which has actually happened in Karamoja region, and they were actually looking at working with the community resourceful persons and the local organizations, probably at sub-county and parish levels. In undertaking this, the key achievements while working with the community at that level, you would see that in a period of, I think that is from September 2020 to September 2011, that is a period of 1 year, they were able to reduce the missed TB opportunities from 8% who were missing at facility level to zero level in 1 year. Because if we continuously miss some of our TB clients, then the TB burden still continues to be within the villages. You would see that even within the same region, that is the Karamoja region, the treatment success rate was actually increased up to 86% from 51%. Therefore, this slide alone speaks to us, telling us that if we actually engage the local people who are influential, we engage the local structures which can command respect at that level, we are able to cause a bigger change. In the same way, we are trying to justify why we need to be in the community. Within even our own communities, we have the high-risk populations. Those are people living in the slum. Those are children in the small schools down there. We have the prisoners. We have people in taxi and bus parks. These are living in crowded positions. But we are looking at interventions that can actually attract to them. In this, looking at the approaches which were actually used in terms of outreaches to the community people, outreaches to the congested places, you can actually see that there has been a registered improvement in terms of finding more people with the TB and leprosy, as you would actually see on the slide projected there. But this has been a support from the USAID-funded entities, PEPFAR-funded entities, the SRRs of TASO, and the others. Therefore, we need to find ways that we can actually move to the ground and realize that we are able to cause a change as a different opportunity. Therefore, what do we learn from this? We have actually 4 lessons that we can draw from the community interventions. 1, when you implement through the existing government structures, you are bound to have success on your program. It is not actually only success, but even the sustainability. Because if you actually worked with the employed health center 2, 3, or 4, whichever level it may be, to undertake your interventions, even if a project goes away, the government employees and the community structures will continue actually to execute their duties because 1, you will have built their capacity, they have actually got interest, and they actually know what to do at a time. 2, by we engaging the community or the grassroots resourceful persons, they actually know what is it that is the problem in their community. What actually always puts us down is we always move to the community and we think we know the problem in the community. But they are the community members themselves who know the problem in their community. Therefore, engaging the VHTs, the community health workers, the other extension workers, it forms a ground for penetrating the community, and you are able to pick on the TB issues and leprosy. The second last is engaging all partners at the different levels, right away from the national, the implementing partners, the district and the facility levels, grounds a component of system strengthening, thereby the continued sustainability and increased visibility of the interventions will be seen. And lastly, we need to embrace the component of timely data sharing. And in this context, the element of using the digital reporting systems has given us a stance as far as moving forward for data availability, which can be used purposely for planning. In most cases, when you use obsolete data, I'm using that word because it could have been too late for you to use it. At times, it doesn't carry a meaning. The information should be actually timely, it should be of quality, and it should be reliable to the extent that when you use it, it is actually giving meaning. Therefore, drawing onto the lessons, what next? We know yesterday we were here, the Honorable Minister, who was our guest of honor, launched an approach called the Cast TB campaign. The question now to the members, those here and those online, yes, the campaign was launched, but what are we going to take on forward? In terms of giving a detailed explanation around the word cast, CAST is an acronym, which is actually basically looking at one, raising community awareness. After raising awareness, the community members will present themselves for screening. After screening, then we should be able to test those who have actually presented with the signs and symptoms that relates to TB and leprosy, so that we actually rule it out that they probably have TB or either leprosy. But in the same way, our interest is to ensure that we even also prevent the further progression of those who probably have latent TB to progress to the TB cases. And it is at this point that we actually also come in with the TPT intervention. Therefore, partners and colleagues out there, we need to look at what is actually moving forward for some of these interventions. Therefore, the campaign which was launched yesterday is looking at ensuring that we actually visit every community in Uganda. We undertake community awareness, screening, testing. Where possible, we need to do the preventive interventions. In most cases, to ensure that even those that have been identified for treatment, we need actually to ensure that they initiate onto treatment there and then, as opposed to the other slide where we saw that we saw people and we missed some. So the issue of prevention, I need to reemphasize it because it has been raised here, that it is a must that we need to ensure that we prevent further occurrence of any other TB and leprosy case. In the same way, therefore, what is the purpose of this? I have actually almost explained this, that our intentions of the CAST TB is basically to raise awareness to the extent that the missing TB cases within the communities and those of leprosy, we actually find them. As we find them, we initiate them onto treatment, and those who actually are eligible for the preventive therapy, they should be given. The current guidance by WHO in relation to the preventive therapy says for every one TB index case, we have to initiate 3 of his contacts or her contacts onto the TPT interventions. Therefore, we need to take it as an issue and a direction that we should move forward with to ensure that this helps to avert the situation. In terms of the specific objectives, we are looking at raising awareness, but for this specific campaign, for me to give more of a highlight, these CAST campaigns are going to happen twice in a year. We are looking at the month of March and the month of September. But for this upcoming campaign, we want to look for 30,313 new and relapsed TB cases. Therefore, the mantle is to us as members, as stakeholders, who have actually an interest of seeing the Ugandans free of TB and leprosy. Therefore, we need to join hands to see this move. But as we do this, we are going to work with our own diagnostic units, which are around 1,700, as we work with the health workers and the VHTs around there. This will be actually crowned by building the capacity of the VHTs and the health workers to undertake this intervention when they have all the probable skills and knowledge to move this forward. What will be the implementation arrangement? This is going to be in a circle whereby we need to have it complete. It is going to be running 360 degrees to the point that we can have it fair. We will start from the national level orientations, the district and regional level orientations, the facility, and then later we'll have the campaign. My point of emphasis is the campaign is going to happen for 5 days. But within the 5 days, we want to see that we reach every household, we reach every village, we reach every sub-county, we reach every parish in a way of combing for the TB and leprosy cases. But nevertheless, even the preventive interventions, either through health education, through the TPT interventions, they will actually happen within the 5 days. There will be a continuation of another set of 5 days to justify if probably Mzamil was found to be TB positive within the 5 days, it means you have to line list my contacts. And if you line list my contacts, it gives you an opportunity in the second week to actually follow up and evaluate my contacts, whether you have TB, and then finally, in the last 5 days, which makes it around 15 days, that will be able to compile and share the findings as you've seen in the previous campaign. Therefore, what do we intend to do and when? You see the chart in front of you is actually giving you the timelines on when we should actually do this. As we speak now, you see the blue there, or that can be blue, or which color is that? Clearly down there, that is the third row from down. It is actually showing you that we have actually started on these interventions way back, but we need to move forward. But what I need to summarize around here is we see January, February, March, April, and May. Our actual interventions for the campaign are going to be within January, February, March. Within those periods, we should be able to move. The national launch was done yesterday, but we are going to do a further launch within the different regions. We know the partners who are here and those online will actually join us to ensure that we have the regionalized launches. This is very critical. If we want to find and control TB and leprosy in Uganda, of course we need the financial support. In a way of summarizing this sheet, you would look at the last row, which gives us the grand totals. The items in red down there, which gives us, I think, that is 8.053544. These monies are actually projected in dollars, and the total amount of money that we need in dollars to undertake on the countrywide campaign for TB and leprosy in Uganda is $9.7 million. But out of the $9.7 million, we have $1.6 million. That is the money that the government has as of now. It therefore gives us a balance and a funding gap of $8 million. This is the balance, this is the gap that we need actually to bridge up. I presume by the end of this conference, the partners on here and those online should actually pick up from this, that as government, we have something slotted in. How do we move forward? We need to find and bridge up the missing gap of the $8.05 million. So what is our call? We ask everyone to join the Ministry of Health, that within the two planned cycles, that is in March and September, you need to join us to implement the campaign in order to find the TB and leprosy cases in a campaign mode. And this will be house to house, door to door, village to village, home to home. In the same way, as you've seen the gap, we need you partners to support us as government to find the missing gap in terms of the $80 million so that we should be able to support, implement, and find the missing TB and leprosy cases as we struggle to meet the global and the national target for God and my country.
Thank you, Charles. Definitely, Musamil. Okay, so thank you, Musamil. Leaving no TB leprosy case behind, and all of you know that these cases are in the community. It will not good of us just to concentrate in the facility. So we need to move to the community. I think you know very well, just like the UPDF, I've moved to the community where the ADF is. So we also need to move to the community where we can be able to find these cases of TB and leprosy, so that we can be able to do that. We have 2 more presentations, so I would expect that you write your questions down. You can share it with the Secretariat. So I want to invite Aldo. As Aldo comes in, I also want to welcome Ross. Is it Ross? Yes? Yes, Ross. You know, initially I had only 4 panelists were all male, but also you know that TB affects men 4 times more than the women, but nevertheless, Ross will here will represent the other aspect of gender. So Aldo, you have 10 minutes. Please keep time.
Thank you so much, our chair and the members, the protocol observed. I'm here to share our implementation experience in the use of mobile digital X-ray machines. As I wait for the presentation to be loaded, I'm called Aldo Brewer. I work for USAID Defeat TB project, and I support the National TB and Leprosy program of the Ministry of Health. Yesterday from the presentation you heard that we are still short of finding all the cases to meet our 90 targets. So X-ray machines are part of the innovative technologies aimed at finding TB cases. So as a way of introduction, the World Health Organization recommends systematic TB screening to improve TB case detection. And conventionally, we've been using symptom screening. And recently, there have been the update of the WHO guidelines to include the use of X-ray for screening purposes. This can be used either alone or in combination with the symptom screening to find TB cases. But X-ray technology has been available in our health system for quite a long time. It has its own challenges of access, lack of functional equipment, supplies, and all that has been there. So the advent of digital X-ray comes in with the window of hope to improve access to X-ray services. And the computer-aided diagnosis technologies use basically artificial intelligence to interpret X-ray images, and so they basically replace human reading. And this addresses the human resource gap of lack of the critical personnel to operate and interpret X-ray images in healthcare settings. So with the use of CAD, we're able to use this equipment to triage and screen patients who could be having TB in order to send them for diagnostic evaluation. So this is the equipment which was acquired by the Ministry of Health through support from the Global Fund. They were placed at the hospitals, 5 of them, and the healthcare workers were trained in use of this technology for screening purposes. So the X-rays were used at a health facility for purpose of screening in LPD, but also they are used, since they are portable, they also used for mobile screening outreach, targeting the TB hotspots and the other populations at increased risk of TB. Yes, so in determining who is eligible for X-ray, the Ministry of Health developed the algorithm for X-ray eligibility. And in this algorithm, basically, we triage all patients who come to the health facility in outpatient setting, those who have no contraindication to X-ray. So these people are screened for X-ray. However, we need to bear in mind that because of the large numbers, there's need to prioritize. So we prioritize the high-risk populations. These include the people living with HIV, contacts of index TB patients, maybe prisoners, refugees. Those populations, when they come to the facility, they are prioritized for X-ray screening. In addition, presumptive patients who are identified basically using symptom screen, but have an initial negative laboratory test are also sent for X-ray services. So through this mechanism, those who now are found to, who are offered X-ray service and have an abnormal X-ray result sent for gene expert test. So in a way, the technology helps to triage people who could be having possible TB, and then they are sent for diagnosis and confirmation before treatment initiation. Not moving. I point this way. Oh, sorry, just behind before. Yeah. So these are the results that we've so far seen from the 5 pilot sites that have implemented the technology in the last 1 year. You can see a total of 5,000 clients have been screened using the digital X-ray machine. And out of these, 800, which is about 15%, we are found to have abnormal chest X-rays suggestive of TB. When I talk of abnormal X-ray, the CAD technology is able to give a score from 0 to 100. And any score above 60% is considered abnormal and suggestive of TB. So those are the people whom we send them for laboratory examination. So out of those, we were able to diagnose 300 TB patients. But remember, the 300 includes those who were bacteriologically confirmed, that is confirmed using a laboratory test, that's 79, and the others were clinically diagnosed. So the clinicians basically use the X-ray findings and tie it together with the clinical findings to make a diagnosis of TB. And so these are the number of people who were started on treatment. So if we consider the yield of TB out of this intervention, it's about 1.5%. But this is much higher than, this is out of people who are screened for TB. It's much higher than if we had used the symptom screening. From our national data, we actually have a yield of, I think, less than 0.3%. So the X-ray still provides an opportunity to improve the diagnostic yield of TB. I'll just run through this, but this is to show the data disaggregated by community versus facility setting. And what you see is that at facility level, the screening which was undertaken at health facilities tended to give a higher yield of TB of about 17 to 12% compared to through a community screening approach where the yield was about 7%. But that doesn't still water down the importance of X-ray for screening outreach in the community, because these are populations that have been targeted, but while you reach the community, normally the population comes and it's upon the implementation to identify the high-risk populations if we are to improve the yield of TB out of that intervention. So there are some challenges. I'll just give a high-level summary, but this is for purpose of information in the use of the technology. The first is that we have lack of adequate personnel who are qualified to operate a digital X-ray machine. You know that this is being a radio emitting device, radioactive emitting device, we needed radiographers to operate the equipment. But in the facilities where we place this equipment, we have had lack of these critical personnel, so we oriented the health clinicians, mainly clinical officers, to operate the equipment. And this, of course, comes with some element of challenge, although they are still being able to contribute immensely to finding the TB cases. Then the other challenges are mainly around the connectivity, basically to do with the software. This being new technology, we do not have adequate knowledge in its maintenance and experience. So there have been some challenges which we've kept addressing as we move on with implementation. So it has helped also us to learn, and as we scale up the technology to other health facilities, we shall be able to improve in the utility of the service. Then the other challenges in operations is the lack of actual delays in obtaining results from gene experts, because some of the sites do not have a gene expert machine on site, so the samples have to be referred to another facility. And that comes in with delays in diagnosis and also decision to treat. However, despite all this, there are a lot of hopes that if we can have one point where we have the X-ray service together with the diagnostic service at one care point. For example, there's now a move towards acquiring mobile trucks which are fitted with both digital X-ray machine and the gene expert machine. That way we're able to offer the screening service and also the diagnosis at the one point of care. That is expected to address the challenge. But also, with the presence of now additional diagnostic technologies like the TrueNut, this can be made available at even the lower health facilities like the Center 3s, so that when screening outreach is conducted, there is at least an equipment available to do the diagnosis on site. So this is aimed at addressing the challenge in delays of getting the results in time. So as I conclude, there are recommendations that we make out of the experience in implementing the digital X-ray machines. One is that government and partners should scale up the use of digital X-ray since it has been proven to help identify additional TB cases, and it requires investing resources to procure the equipment since they are quite expensive, but they help to reach the communities in need of the service. And then we also need to invest in mobile TB clinics. This is the one which I told you has integrated platform where we have both the X-ray machine and the gene expert machine all in one clinic, and these are movable. So basically they are mounted on a truck and they're able to reach up to the ends of the community where the people are in need of the service. Through this mechanism, we're able to reach out to people with the service and able to improve TB case detection. Then there's need to strengthen capacity of clinicians in the use of digital technologies, because now we are moving towards digitalizing all these things. So we need them to have capacity to interpret X-rays and all that. As I conclude, I would like to acknowledge the Minister of Health that has led the implementation of this important innovation, the Global Fund that has provided the resources towards acquiring the equipment, you said the FTB project towards providing the human resource to support these interventions at the ministry, and also the patients and the healthcare workers at the facilities where the X-ray machines are stationed. I thank you so much for listening.
Thank you, Dr. Aldo, for taking us through that. Just note down your question. We are going to receive the last presentation by Rose Kengozi, the Senior Medical Officer. Definitely you will not have the TB story complete. It will be incomplete if you don't add in leprosy. So we really want to listen the aspect of leprosy, the forgotten disease, summary of the findings from the WHO leprosy program review. Rose, you have 10 minutes to take us through the presentation.
Thank you for the opportunity, especially to be a voice for leprosy in this stakeholders engagement. Yeah, that is my name. I'm called Kengonzi Rose. I'm a senior medical officer, but I'm also the National Leprosy Coordinator. I'll be taking us through the findings of the Global Partnership for Zero Leprosy and the WHO Leprosy Program Review that we did in October. That was conducted in October 2021. That's the outline of my presentation. For the sake of time, I'll move on. For the sake of those who don't know leprosy, who may be hearing about leprosy for the first time, or even just reminding us about leprosy, just to emphasize that leprosy is an infection that is caused by a bacteria called Mycobacterium leprae. And usually it affects the peripheral nerves, the skin, and the mucous membranes of the upper respiratory tract. And important to note is that it's the world's oldest recorded disease that is caused by a bacteria and very highly stigmatized. Yes, the bacilli look almost similar to the ones that cause tuberculosis. Basically, if you look at this slide and if someone didn't tell you that this was a skin smear, you can think this is TB. So on microscopy, the bacteria looks almost completely like TB. Just also to note a few facts about leprosy. It affects all ages and both sexes, and causes progressive and permanent damage, usually to the eyes, to the limbs, to the nerves and skin if it is not treated. Maybe good news is that 95% of the people who are exposed to the disease do not actually develop the disease. Only 5% go on to develop the disease. And the transmission route is exactly not clear, but it's thought to be via droplets from the nose and mouth during close and frequent contacts of untreated cases, just like TB. And just know that it is not as highly contagious as tuberculosis. Just to note that if leprosy is not treated, which begins usually as skin patches, there are complications, and these are some of the pictures of some of our patients that we are treating that are delayed to be diagnosed with leprosy. And yeah, those are possible complications that can happen. Briefly, to also tell us about what is happening globally according to leprosy. For the last 10 years, there has been a gradual decline in leprosy cases, but it is really gradual, very slow decline in the cases of leprosy. And just also to take us through the targets, we have also global targets for leprosy 2030 by 2030, according to the Global Leprosy Program Strategy, and therefore, the first one is that by 2030, there should be at least 120 countries with 0 orthogonous cases, and this means indigenous cases, and we hope that Uganda will be part of the statistics in this target. And then the other target is that by 2030, there should be at least 70% reduction in the annual number of cases that are detected. So if we are to talk about Uganda, by 2030, there should be less than 70 cases of leprosy reported by that time, if we are to compute it in view of the report of 2020 year. So also by 2030, there should be a 90% reduction in the rate per million population of new cases with grade 2 disability. Grade 2 disability means physical disability due to leprosy. And the last target is by 2030, there should be a 90% reduction in the rate per million children of new child cases with leprosy. Just a brief summary, those are the targets, the milestones that are hoped to be achieved by 2030. These are just basically in figures what I've just talked about in the previous slide. Just to let us know how we are doing in terms of the targets, in terms of implementation, by 2020 status, just comparing how we have been faring, we still see that by 2020, we were expected to be reporting less than 1.3 per million population of new cases with grade 2 disability. And we stand at 2.2 per million, so we still need to work hard in that indicator. The other indicator is also looking at the new child cases with leprosy. By 2020, globally, it was expected to be 7.8. We are at 1.02. Maybe the other indicator is the number of countries with 0 new cases. We're expected to have at least 50 of the countries that report cases to be reporting 0. Of course, we are in red because we are still reporting cases. And then the other one is the number of new cases detected being 184,000. And I think this was achieved because last year, the total detected was about 170,000. So, but as a country, we registered 234 new cases of leprosy. That is a map just to show us the distribution of cases for leprosy. We see mainly most of the cases are from West Nile, specifically Yumbe and Zombo districts. But significant to note is that almost all regions reported some cases of leprosy. So maybe other regions are not reporting because they are not looking for the cases, but that is the distribution of leprosy as per 2020. Just looking at the trend of leprosy in the last 5 years, we see we have been seeing a significant increase in the number of cases reported, specifically 2019-2020. And these are the cases which are reported. I'm sure there are some districts that are treating cases of leprosy that did not report so. Yeah, it's a worrying picture. Although the numbers are few, we are not sure that maybe we are even missing cases that are not coming to the facility, but also that the trend is becoming higher and higher, as illustrated by the graph. This one was basically to show us also that cases of leprosy are there, and we see almost all regions reported leprosy, specifically West Nile, but we see other regions. We have Toro, we have Lango, Bunyoro region is also reporting a significant number of cases, and Bugisu Bukedi. But important to note that all regions at least reported one case of leprosy as per the data of 2020. This I will not talk about. Yesterday, our Assistant Commissioner talked about our strategic objective for leprosy. So that's just a brief background about leprosy. So I'll take us briefly about the program review findings that happened when we did our program review. That was in October. And why we did this review, the Global Partnership for Zero Leprosy has a vision of seeing zero leprosy cases by 2030. So, as a country, we wanted to have a country-specific zero leprosy roadmap. We also wanted to develop a roadmap which will help the nation to achieve zero cases in line with the new strategic plan and in the new WHO NTD roadmap and global leprosy strategy. So this was a prerequisite to coming up with the roadmap so that we are able to realize zero cases by 2030. And zero cases, Dr. Kauma yesterday had told us it is zero new cases, zero disability, and zero stigma by 2030. So the objectives in summary, we wanted to do a comprehensive and in-depth analysis of the leprosy situation. We wanted to evaluate the ongoing process of integration of leprosy control into the general health services in view of the revised WHO Global Leprosy Program strategy. And we also wanted to assess the current surveillance system and identify key issues that needs to be strengthened in terms of leprosy surveillance. I don't need to take her through that. Those are some of the pictures of during the program review, especially the field visits. So in summary, these are the findings. So from the epidemiological situation evaluation, it was found, of course, that as I had said, we see the trend of leprosy, the cases are increasing, but significantly is that there was a high proportion of grade 2 disability, especially in 2030, meaning that almost a third of the cases that reported in 2020 already had physical disability. And there was also a high proportion of children, which signifies ongoing transmission. When they looked at some of the key indicators, following up the midterm review that was done in 2019, looking at four specific indicators. The first one is prevalence of grade 2 disabilities among the new cases. And of course, we are doing badly. We are at 2.22 per million population. The target is supposed to be less than 1 per million. In terms of the percentage of new cases with grade 2 disability, the proportion is 39.3, which shows that we are getting most of our cases, a big number of our patients when they already have grade 2 disability, that is physical disability. Then when they looked at the percentage of leprosy endemic districts with annual plans that contain leprosy activities, it was found that we do not have any districts that have annual plans containing leprosy activities, which is unfortunate, especially for West Nile, the regions that are reporting high cases of leprosy. They don't have specific plans to do leprosy activities in order to lead to the control of leprosy. Yeah, the other issue which is also unfortunate is that we are also seeing a significant proportion of children with grade 2 disability, 6.9%, but important to note is that the treatment success rate is good at 90% at least, and also the persons affected by leprosy that are accessing self-care support is also good compared to the target by 2018. We are at 42%, so that's some good progress. In summary, these are the strengths, weaknesses, and opportunities and threats of the leprosy control program. I'll look at mainly a few of them. One, there's a high commitment at national level. We have DHIS2 rolled out at all levels. We have training materials available for our healthcare workers. We have a high treatment completion rate. Maybe just going to the weaknesses which we need to work on, and this is a very important platform for us to discuss how we can help to remove these weaknesses and be able to control the leprosy better in our country. One, we have no dedicated budget for the regional and district TB leprosy supervisors. Yeah, and then case finding is mainly passive for leprosy, but we are happy to know that now we have the new strategy of the Cast TB leprosy campaign. Yeah, then the other thing is that, of course, most of our cases, we are seeing them when they already have grade 2 disability, which is unfortunate. Yeah, that a patient comes with a patch and then lingers around all health facilities, and then by the time they are got, they already have established disability. Yes, of course, the other issue is high unmet needs for assistive devices. We have opportunities, we have existing partnerships with JLRA, which has supported the program ever since the inception of actually NTLP. JLRA has been our main implementing partner, but we also have other IPs who are present here who can also be part of, making sure that they fund part of the leprosy activities. Yeah, that's an opportunity. We have a national training institution that is still active to do training, and then of course the community development programs. The threats is one, there's lack of awareness of the persons affected by leprosy, of the community development programs. There's high healthcare worker and community stigma. It's a big issue for leprosy control. And of course, the other issue is that there's inadequate mainstreaming of leprosy into district programs. And
Rose, I hope you...
Almost there, yes, yes. So when we looked at the process of leprosy integration, we see that leprosy is integrated, but the issue is that general healthcare workers have very limited knowledge and expertise to carry out the expected tasks. One of the other deliverables was developing a roadmap, which we are doing in consultation with our local expert, Dr. Kauma Joseph. And there are other recommendations that which came out during after the review. Of course, setting up a zero leprosy partnership is very crucial, including all relevant stakeholders, so that there can be high-level advocacy. And also making sure that all new DTLSs and facility focal persons are trained making sure that the needs of the persons affected by leprosy are taken into consideration. NTLP should implement contact management, including the single-dose rifampicin as post-exposure prophylaxis to be a routine program package that is available following each diagnosis. At the moment, we are doing this in research mode, and even actually this morning I received news that we will be getting some more funding to increase because this has been done in 2 districts, but now we have the opportunity of expanding to 3 more districts. So yeah, but it is one of the recommendations that came out of the program review. Then of course, increasing active case finding, door-to-door approach, making sure that the opportunities for integrating resources for leprosy and TB are fully realized within the program and other health sectors, because we find that most of the activities is TB, yet it is a national TB and leprosy program. So if all the activities and opportunities could be realized, for sure we should be able to have 0 leprosy by 2030. And then all health training institutions, including leprosy in the pre-service training curricula, because it was found that many of the new people out of medical school actually don't know how to diagnose and treat leprosy. Yeah, the 0 partnership, I said about it. Yeah, so way forward, we are finalizing the roadmap, which we should be able to be launched, and then we hope to form a national 0 leprosy partnership and costing activities to support the roadmap, resource mobilization, and then of course implementation. We are blessed to have global partnership for 0 leprosy because it has actually said that they would be very happy to make sure we go through this roadmap development process until it is actually realized. So thank you so much. And yeah.
Thank you, Ross. Let's applaud all the presenters. I know it's very difficult to chair when you have limited resources of time. We are going only to take 3 contributions, and I would really like that if there are contributions other than questions. So the mic is there when you first come, and we'll hear from you first. But as probably members prepare to come, I had my own question to Aldo, specifically looking at the 5 X-rays and looking at only 5,000 cases in a year is looking at an average screening of about only 3 to 4 per day. Is that not underutilization? I think we should be able to set a target and be able to see what are the numbers which we have. I had to be very fair to Ross and also fair to leprosy for us to be able to listen. So it looked like there are, I don't know in the online I think we will not be able to respond all the questions. We still have presentations which will need almost a full day. I need to allow the next chair to step in. So I don't know if anybody can quickly run us through the online question, because it looks like physically there are no questions. I mean, you come, the 3 people to reach there first, those are the questions which we shall take. And those 3, or they have come 5. There are 6. So just one question each, just a short comment. Don't start making a presentation. So let's start with the Pande.
Is on a presentation on the use of digital technology to screen for TB. I was looking at the it's like we are changing the normal routine of screening from history examination, then investigation. So, and looking at the fact that this is I wanted to know what strategies are there which you have to ensure the support. We strengthen the screening using the history and also examination. As much as we use the digital technology, we shouldn't forget that, because over 70% of the diagnosis can be reached by screening. So increasing their capacity is also very good. And also the other bit of it is the cost implication. If I'm to my uncle, my auntie down there in the village, I don't know how he can really access this, the cost in terms of what he pays from the pocket. Okay, thank you so much.
Thank you. You are almost about to fail the question when you go beyond 2 questions, because I said 1 question each.
Thank you, Mr. Chairman. Mine is just a suggestion to the approach of caste, that while doing the awareness, we should also focus a lot on the community leaders. Community leaders, political leaders, councillors, in addition to the VHTs that have already been notified. And the second one is about the gap. There's 1.6 million US dollars, but what is required is about 9 point something. I would suggest that there be established a multi-sectoral kind of management committee to help the brains around in soliciting and negotiating for the remaining gap, both at local government and central government and in the partnerships. Thank you.
Thank you. Also say your name quickly.
Thank you very much. I'm Isavirie Moses, DTLS Vuyende. Mine is concerning the caste strategy. When you look at it, it's actually it's likely to really push us far concerning this detection and screening. However, the concern, actually from experience, it has been that each time we have to have such campaigns, as if prior kind of arrangements are not well done, whereby at the end of, and even during the campaign itself, supplies, especially in terms of drugs, somehow we end up suffering. And it looks as if we've not planned well, and yet we know well that for a campaign to be successful, we really need such inputs to be less before we can be able to really come up with good results. Thank you.
Thank you.
Thank you, Mr. Chairman. Peter Lochoro from Kuam. Very quick question related to the digital x-rays. I think we understood that, that there is a desire to have this go beyond hospitals or health center force. The question then is, with the quite tight atomic energy regulations, how can we go about this for very small health centers which may not have that kind of infrastructure that would be acceptable for x-rays? Thank you.
Thank you, Peter.
Thank you very much, Chair. I'm Tinka Betty, Deputy Kawa Masaka. My question goes to Dr. Kengonza on leprosy. Other than the other factors of close contact, are there other conditions? I'm not from medical ground, I'm an administrator. Other than other factors of close contact, are there other conditions that predispose somebody to the infection of leprosy? Like, for example, I come from Masaka and we are surrounded by learning sites and a lot of floods. Most of our learning sites in Kakata, Namirembe, Marembe are all flooded, and kids are playing just in the flooded water anyhow. I don't know whether such conditions can expose these kids to the infection. Thank you.
Thank you. Okay, LOC1.
Thank you, Chair. LC1, Dugum George Upeto. I'm here to answer questions on caste, because I want to make caste very easy for people to believe in. Caste is supposed to go to the 70,000 villages we have in this country, And we want to say we shall leverage on the structures and the resources which are there. Where are the finances? COVID has taken the finances there. Every village has, in the new community engagement strategy, 5 to 7 village health team members per village. Already we have taken ICCM into those villages. We have taken nutrition services to those villages. We just have to take TB to those villages in that simple manner. We don't need to reinvent the wheel because the structures and the resources are already there, riding on what COVID has put in the community. Thank you.
Okay, thank you. So Stavia, you'll quickly get in touch with Dr. Dugu Penso, so the Commissioner of Community Health. There is a question from one of the parents or the fathers of TB, Dr. Peter Eriki. So wherever he is, if you can get him the mic, he could be able to ask his question because he couldn't come in front.
Thank you, Chair. Mine may not be a question, actually, but feeling very satisfied in my life, particularly about TB in this country and leprosy. Going back to 1978, when I was finishing my master's degree in internal medicine, I decided that I should go for TB. People thought I was crazy because there was no TB program. Not even in any single country in Africa had a tuberculosis program. But I endeavored to go, and that was posted. At that time, the TB program was being headed by Indians. There was one called Patel, he was a chest physician, but also was tuberculosis person. Then Dr. D. I saw both of them, and I really worked with Dr. D very closely, and was based in Olumlago. After finishing the postgraduate in public health, I was posted to Olumlago to head the TB program and chest diseases in Olumlago. I may have taught some of you chest medicine and TB at that time. There was no tuberculosis program, frankly speaking. And I'm so happy that I attended this meeting yesterday virtually. I saw everything, listened to everything. And in this room, if I could ask another individual to stand up, Dr. Datu, are you here? There he is. And there was one called Timo Doi. Unfortunately, I think he passed on. He was the first one when I left for WHO who took over that program. In fact, I had a lot of difficulties when WHO called me. I did not apply for a job, but I was called because of what I did. When I described the changing patterns of tuberculosis because of HIV. Typically, TB gives cavitatory disease in adults. But this time, it was changing to be miliary, just like in children. When I gave that in a world conference, they invited me now to be allowed to go to WHO. They said for 3 months. But 3 months became 22 years with WHO. At that time, the minister then was the late Nekion. He told the people, why should you leave this the only man in TB to go? When they asked me, when you are going, whom are you going to leave? I gave them a list of 5 boys I trained. And one of them was Dr. Datu, who is here. And they left the words which I promised the ministry. So in the ministry, when I was in WHO, I did not know why NGOs of leprosy were resisting when I suggested that why don't you combine the two programs? I didn't know until when I went to the WHO. That's when I realized they were getting a lot of money, I think over $1 million a year for leprosy. So the late Dr. Luit, I told him, Dr. Luit, please, don't talk about money. Talk about combining these two programs, because at that time leprosy was on the decline, and TB was a program which was not even addressed. And there are similar ways of controlling. When he talked that way, and I'm sure Dr. Kauma is in this room as well. Kauma, you around? There he is. He will tell you how I went around and managed to combine the two programs. And then I was then transferred from Geneva to Afro, and I became the regional advisor for tuberculosis and leprosy. Believe you me, during that time, in the 6 years when I ran that program, single-handed, in the regional office, the only person was one person, me, up and down and so on, 46 countries. There was no TB program in the regional office. But I managed to stimulate processes until working with the people like Adatus and other people in other countries, national programs become a reality. And that was the beginning of DOTS. Now, what I'm so glad about, when you fight a disease like this, and you get such wonderful things happening in your lifetime, you feel so fulfilled. And as you can see me in front of you, and I think Stavia, the lady heading the program, really needs a lot of appreciation. Pushing this program, which was really a neglected disease. I should tell you, I was among those who made a lot of noise. One in 1990, in a conference in San Francisco, of TB, of HIV/AIDS. I was one of the keynote speakers in a plenary, where even the late Jonathan Mann, who was a director of global program in Geneva, were on the same podium. And I told the world, we need to support that lady, using all those mechanisms, and more so, this Paris model, take advantage of it. And those guys talking about engaging communities, this is a big opportunity to flush TB out from those communities.
Thank you, thank you.
Well done, thank you. Congratulations.
Thank you. You know, when generals speak, the most important thing might actually come at the end. So if you stop, you actually miss what? I want to quickly run through some of which came from online. Where is the National TB Reference Lab for leprosy? Where is the National TB Reference or Leprosy Reference Lab for leprosy? What plan is there to bring the private clinics across the country to the CAST TB campaign so that no TB is left behind? Thanks for the wonderful knowledge. Is there a way private health centers are helped with supplies in testing? Because we lose many on the way when it comes to referrals due to lack of reagents. From the presentation on chest X-ray play a key role in clinical diagnosis. Most poor performing districts in terms of case detection are those with no district hospitals, no X-ray services, means of health prioritize chest X-ray machine in these districts. Nice performance, but there are issues of all microscopes in the DTUs and facilitation for the microscope EQA program. The community engagement in May has tremendous achievement, but the payment for VHTs has taken up to 6 months. Dr. Aldo, is there a plan for the quality assurance for the CAD chest X-ray results for diagnosis of TB? Our children also part of reported cases. So you've seen that's how big my task. So I will give each presenter 1 minute to respond to, so that I can complete my story as the chair of this session. So let me give 1 minute. I can start from the community, and then I will come to the other presenters.
Thank you, Chair. Basically, to respond, it's all about what plans to integrate all partners into the CAST TB. I'll not basically look at only the private, but any other individual. By saying that all partners or stakeholders, this starts from the village level, where we have the community members themselves, and I know we also form part of the community in one village or the other. So basically, we'll have an integrated approach into the execution of the CAST TB campaign, whereby we'll engage everyone to play his role. Thank you.
So, thank you. I have quite a number of questions, but I'll try to summarize them. I'll start with what the director asked about the underutilization. I think it was more of an operational challenge because when this equipment had just come, we had to train the healthcare workers, but some of them did not take off immediately. Some actually took almost 6 months to start using the system. However, now as I speak, the utilization has dramatically increased, and we are likely to improve on the utility of the service. Then the strategy is to ensure continuity of symptom screening. I think X-ray is not replacing the clinical assessment of patients. It is just used as to complement the screening efforts. And I said we are prioritizing the high-risk populations. This is because from the last prevalence survey, it was found that about half of the diagnosed TB patients did not have symptoms. So we are trying to target that population of people who might have TB yet they do not present with the symptoms. And we stick to the algorithm when using the X-ray. And then the issue of scaling up X-ray to lower facilities, I think the plan is not to take X-rays to the lower facilities. However, it is to make X-ray accessible to the people in need, those high-risk populations. So what we are going to do is the X-rays are being targeted to be in every region, but then they'll be used for screening outreach to TB hotspots. And then the issue of maintaining the standards for Atomic Energy Council, this equipment first certified by Atomic Energy Council before they are like operational license. They have to meet those basic standards. And one of the things is to ensure that there is somebody who is registered as a radiologist in charge of that equipment. So we are observing those minimal requirements for Atomic Energy Council to get the operational license to use the equipment, and then also supporting the sites through supervision, because we coordinate the services nationally at the NTLP. Then there's a question about prioritizing the poorly performing districts. I think that one will be achieved through regionalizing the equipment. As we get more equipment in the country, we want to make sure at least every region has a portable X-ray available that can be used to reach out to the districts that are in need of the service through outreaches. Then the quality assurance for CAD results. I think CAD as a technology has been rigorously investigated. There are a lot of papers about it. So at national level, we may not have a system to do quality assurance. However, there are plans underway to do a diagnostic study to validate the appropriate threshold for CAD for our settings. But that is still in plan. However, we rely on what the recommendation of the manufacturer, because this is a WHO-approved technology, so we rely on what studies have been done to validate the equipment, and then use, for us, we are implementing and scaling up the technology. Thank you.
Yes, to respond, there were two questions that were towards leprosy programming. The first one was concerns about who is at risk of getting leprosy. Leprosy is transmitted the same way as TB, so the same risk factors for TB apply to leprosy. But significantly, according to studies, people who have not had BCG vaccine are more prone to getting leprosy. And of course, if you have a close contact, if you're in a close contact with a person with leprosy, especially bacillary leprosy, which is the severe form of leprosy, you are at risk. So other risk factors, yes, poor conditions of living, just like TB, risks for also developing leprosy. The second question was about national reference lab for leprosy. That's a good one, but the main issue with leprosy currently now is really capacity. Yeah, capacity building, also at the national level. Yes, at the moment, we do not have a national reference lab structure for leprosy, but it is one of the action points according to our national strategic plan to make sure that that is in place. But we have also an opportunity of training so that we could also be able to have really some people that are well-trained and oriented in leprosy at national level, especially in issues of resistance, because some other countries report a few cases of resistance to rifampicin. So as a program, that is a key area that we identified, and there's an opportunity actually for training, and I think it will be realized because the person to be trained has been identified and will do that. But apart from that, as I said, diagnosis for leprosy is like for TB. The only difference is the sample, is the skin smear. So sometimes when we have had, when there are challenges at a district level, not sure about the skin smear, yes, samples have been transported to the national TB reference lab. Yes, as I said, that's an opportunity that we need to embrace as a program, and we'll see how to go about it. But it's mainly to do with capacity building.
Thank you, Rose. Last, I really once again want to applaud the presenters. I think they have done quite very well, so let's appreciate them. I also want to mention that if it has been very hard for me to chair, it's going to be harder for the next chair because the time is really going to be of a big constraint. So I hand over. Thank you very much.
Thank you, Chair. Can we clap for the chair? And I'm challenged, being within a temporary employment, and you are seated among the key stakeholders. So the challenge of having elders to be hurried was so much on me. Now, may I now invite the chair of the next session, Dr. Raymond Biaruhanga. And as you are aware, we have just 30 minutes to the arrival of the chief guest. So, Doctor, take it on.
Thank you. Thank you very much, our Master of Ceremony. It's very difficult to enter the shoes of the director. So if the director has directed beyond the time, I don't know what I'll do. But can we have the next presenters come on board? Thank you. We'll give you about 1 minute to walk here. I'm joined by my co-chair, Dr. Walusimbi. You can introduce yourself.
Good afternoon, colleagues. My name is Simon Walusimbi from the WHO Country Office.
we shall, since the MC has told us we have 5 minutes, we have 30 minutes to go, so the next presenters will have at least about 5 minutes. We have quite a number of them. So, still as a Wednesday, Rita, I see Simon Muchuro here. Eric over there, please be ready. We have someone representing Fred Semitala, so she should also be ready. Professor Harriet Mayanja, Professor Achilles Katamba, I see him there, so he's also ready. Dr. Christine Sekaja and Jimmy Sewanyana from Lira. So be nearby, and once we call upon you, you go ahead. So Dr. Stella Zawede, please, over to you. You have 5 minutes to go. Thank you.
Thank you very much, the chair of this session, Dr. Avia Ruhanga. Ladies and gentlemen, protocol observed. We're going into the session for TB research, and in the next 5 minutes, I am going to simply set the stage on behalf of the Assistant Commissioner for the NTLP program. Yeah, so just as we have all our programming led and by the National Strategic Plan, the NTLP goal is to have all research that is being carried out in the country embedded within a national TB operations research agenda, because this ensures that all the research that we do feeds into the program, informs the program, and can further programming. So the National TB Research Agenda, next slide please, yes. So it's embedded within the key documents that guide TB programming. It's embedded within the third pillar of the NTB strategy that calls for research to optimize implementation of diagnostic and treatment innovations. It's also aligned with the Ministry of Health Sector Development and Strategic Plan for Uganda that calls us to improve collaborative mechanisms between planners, research institutions, and academia, and to create a culture in which research plays a significant part in policy formation. It's also aligned with the NTLP strategic plan, particularly with the objective to strengthen systems for effective management of TB and leprosy. So the current plan was developed in 2018, and it was launched at the World TB Day celebrations in Tungamo district in March 2019. It runs until next year, and the overall aim is to generate consensus between the NTLP, the research community, development and implementing partners on TB research priorities that will generate evidence to improve TB control and enable us to achieve the NTB target. The development process was multi-sectoral, and it involved healthcare workers, policymakers, academic researchers, health managers, and members of civil society. Yeah, so this is really small. No, I think you can see it. Yeah, so it went through many steps. The first step was to do a SWOT analysis of the TB response, the country TB response at that time, and to find the areas of weakness and the opportunities which we can use to guide priorities. Then we developed country priorities through consultation with a number of stakeholders, and we kept on refining these questions at different meetings as different stakeholders kept on giving additional input. The NTLP, then partnering with Makerere University, built capacity for operations research for program officers through the SORT-IT course. And since then, the NTLP has been continuously advocating for public support for the research agenda. And this is one such meeting where we are advocating for support for the operations agenda. Next slide. Yes, so the following slides are going to very quickly go through priority research areas that are outlined in this operations research agenda and point to areas where progress has been made since 2018. It's by no means complete, so for a complete review of the NTLP research priorities, please go to the Ministry of Health website and read through the operations research agenda. Or if you get the presentation, please click on that link. It will take you directly to the entire document. Yes. So the priorities are sort of grouped around the the cascade of care. So case finding, case holding, TB preventive therapy, TB HIV, and MDR-TB. And in TB case finding, there has been a question on optimization of the screening algorithm, and that's the work Dr. Aldo presented in the previous session. And that work, that comes from the prevalence survey that showed us that our symptom screen misses almost half of all cases. So there's ongoing work, and there's also work that's been done by the MLI, the Exit TB, to see how to optimize the screening algorithm. Then there's also work to optimize access to healthcare services, particularly for men and other high-risk populations. There's ongoing work by the NTLP to answer this question, the gender and key population assessment. There's ongoing work by the IDI, I think, which has been presented in a poster on differentiated service delivery models. There is work to assess the prevalence of TB in prisons. There's work to engage the private sector, which will be presented by my colleague, Dr. Christine Sekadja. And also there is the big cast TB from the community that was presented in the previous session. Then there was also at that time a very important question on how to improve retention along the cascade of care. And over time, we've seen completed work on 99 dots by Dr. Achilles, ongoing work on V-dots that have shown that you can use technology to improve retention along the cascade of treatment. Yes, and then there's also been, there are also questions on how to incorporate use of digital technology for TB screening. Aldo has presented CAD for TB. At IDI, we are validating the technology and finding an appropriate cutoff for this, for our Ugandan setting. That work is led by the NTLP in partnership with IDI, and it's ongoing in Gulu. And there's also, there were questions on how do we promote early diagnosis, particularly among children. And Dr. Eric Wobdea and in Mulago, they are using alternative specimen, apart from sputum, stool and urine, and I think he's going to present that in just after me. So he'll tell us all about it. So there's ongoing work there to see how to do non-sputum-based diagnosis to be able to increase early case detection. Next slide. Yes, then under TB HIV. Yes?
Time up.
Time up. Okay. Summarize. Okay. Yeah, so there are, next slide, please. When we get the presentation, there are also questions on MDR-TB, alternative modalities for service delivery, particularly community-based care, now that we have all oral regimens, which we didn't have then. And there's work that's being done by USAID Defeat TB, led by Dr. Ebo, on community-based directly observed therapy for MDR-TB. Next. Yeah, okay, next slide. Sorry. So all this work is presented every month at the National TB Research Forum. And it's a forum that brings together academics and implementing partners to share the current research landscape. And the next slide, please. Yes, and the objectives of this forum are to increase in-country visibility of local and international TB research so that we as programmers know what's going on in the research world, and we don't have to travel to India to the Union Conference to hear about research that's going on in Uganda. And then to facilitate development of collaborative research links between researchers and programmers, and to support the utilization of in-country research findings and quicken the research to implementation cycle. I'll go straight, so these are the people who've participated in the research forum over the last 3 years, and I think I'll go straight to the challenges. Yes, that's my second last slide. And so the challenges for research, as we've learned from TB programming, it's limited funding for the NTLP to answer key questions, sometimes limited consultation with the program or reference to the national research agenda as we design our research projects, and leading to ad hoc engagement by some projects midway through the research life cycle. And there's also, although we've made strides and improved in involving program officers in research, we need to also involve them in the dissemination and publication of key research findings. So my last slide is the way forward. So the NTLP is working. There's a lot of findings that are coming out, a lot of data, a lot of good things that are coming out of research that are all relevant to our setting and can propel us to even go beyond the 80% case finding that we had this morning. So the NTLP is working to ensure that results from all these ongoing studies are incorporated into policy and practice. You heard in the morning, the NTLP is scaling up 99 dots. This is a very recent, I think the results came out last year, but to see that the NTLP is already scaling it up, it means we are progressing, you know, we are shortening the research to policy to practice life cycle. And then the NTLP, as the COVID-19 pandemic has emerged, new challenges to TB care have emerged, and there will be efforts ongoing to update the research agenda for it to reflect the current environment in which we work. Finally, I'd like to acknowledge, just the acknowledgement, all the people in this room, all the development partners, all the implementing partners, everyone who has participated in research. A special mention to the USAID Defeat TB project, which really started this, the drafting of the research agenda, working very, very closely with the Assistant Commissioner of the NTLP, and has been continually facilitating the NTLP Research Forum. And a special thank you to all the researchers in the room and all the programmers and everyone who has joined the forum and made a contribution, and together we can end TB. Thank you.
Thank you so much, Stella. So colleagues, what we've just received is a status on our national TB research agenda and the progress that has been made thus far and the way forward. Once again, thank you so much, Dr. Stella. I would like to upload the presentation for Dr. Simon Muchuro. Simon?
Yeah, feasible. So,
right, okay.
Simon Muchuro.
So 5 minutes, colleagues.
I'm a TB prevention advisor.
Just before you
at the national
proceed, Simon, a bit of guidance. Colleagues, in the interest of time, we are encouraging you to make your presentations in about 5 minutes or so, such that we keep within the agenda for the day. Thank you. Over to you, Simon.
Yeah, so I'm going to present to you one of the studies that the TB program has implemented. And I'll present on behalf of a group of investigators with the Assistant Commissioner as our PI. Next slide. Next slide. Next slide. Next slide. So this study was done in Arua, Hoima, Soroti, and Mulago. Next slide. Next slide. So we had the TB teams in those hospitals visit 69 TB patients' homes where they found 355 household contacts. They offered these household contacts a test for TB infection, not disease. So they screened these household contacts. They screened these household contacts for TB and found they did not have TB disease. Then they offered them a blood test to see if there is TB infection in their bodies. 352 of these household contacts accepted to have the test. So the result was acceptability of this test at community level at the patient's home was 99%. Of those who were tested, 96% of them reported that they had an excellent or good experience. So we had an uptake of 99% and acceptability of 96%. Now, of those that were tested, 1/3 of them, 33% of them, tested positive for TB. TB infection, not disease. So they had the bacteria in their body, but there was no active disease process. And however, because they have infection in their bodies at any one time, maybe if they are malnourished or they develop HIV or something happens, they may develop disease. So, of those, we offered, of those that tested negative, 231, we offered them a repeat test at 9 months. We had COVID in between, so we were able to reach 151 at 9 months, and of those that we tested at 9 months, or those that tested negative, we repeat tested them at 9 months, 5 of them tested positive. So we got an incidence, a 9-month incidence of 3.3%. That means those who changed from negative to positive after the initial test were 3.3%. Next slide. Now, of those who tested positive, the 115, again, due to the COVID issues, were able to reach 86 of them at the 9-month period when were able to go back to their homes. Now, they had TB infection, and if something happens, they may develop TB disease. So we gave them a medicine called TB preventive treatment to clear the TB germs in their body so that we reduce their risk of developing TB disease in the future. So of the 86, 81 took up the test. And so we had a TB preventive treatment uptake of, I can't see the figure here, 94%. And then they took the treatment for 6 months and were able to follow them up. And of those that started, 82% of funding, can we, our funding was reprioritized for COVID. So
give you 2 more minutes so that you close smoothly. 2 more minutes, Simon.
Okay. So we were able to, so the completion rates were similar to routine program. So what do I conclude from this? 1/3 of the people living with TB patients have TB infection, and we need to give them preventive treatment to clear the TB germs in their body. Therefore, as a country, we need to procure tests for TB infection for these household contacts of TB patients. We need, I think, $2.9 million if we are to reach the number of TB patients in, the household contacts that we need to reach to meet the UN high-level meeting targets. We also looked at the costs of implementing this intervention. And we looked at costs like the main drivers of costs were transport and human resource costs. Next slide. Previous slide. Previous slide. We also looked at the barriers and enablers of testing in the patient's homes. We found the enablers to be high community demand, the fact that tests are automated and free. The barriers were transport costs, bad roads, the fact that the tests were sophisticated, a national capacity to test, poor workspace in the patient's homes where the tests were carried out, the lack of privacy in the households, and stigma. Can we go to the slide of conclusions? So I've already concluded, one, that we need to what? Procure tests, about $2.9 million that we need for these household contacts of TB patients across the country. Two, of course, there were a number of barriers to home-based testing. Three, there's high uptake, and there was high uptake and similar completion to routine program, and the main cost drivers were sample transportation and health worker allowances. Next slide. So the country should consider home-based testing for TB infection to reach national targets. It should roll out latent TB testing to prevent the overwhelming majority of household contacts from receiving TB preventive treatment they do not need. And testing should be decentralized to drive down sample transportation costs. Thank you. I would like to acknowledge the household contacts and the index patients, QIAGEN that provided the test, University Research Company, Defeat TB, and IDI that provided technical assistance, the World Bank that funded the project, the hospitals, Mulago Arua, Hoima and Soroti, and the Ministry of Health. Thank you very much.
Thank you very much, Simon. A round of applause for him. So the next one, it's a recording. Dr. Eric up there. Do you have his presentation ready, uploaded? Okay. If not, we can continue for now. We will now call upon Dr. Fred Mitala. Is his presentation loaded? He's coming? Okay. So in the meantime, as you load for Eric, the one who is representing Fred Mitala, please, you can go ahead. You have 5 minutes. Thank you.
Okay, thank you very much, the chair. I'm Rogers Katwesje, and I was part of the research team that used implementation science methods to see how we can integrate the screening of TB and COVID-19. So we conducted this study at Chirudu National Referral Hospital, and we have already, next slide, we've already been informed that when there was the onset of COVID-19, there was disruptions in the TB services, and that included also TB screening. Next slide. Next slide. And that is data from the DHIS2, where we saw that in the first quarter of 2020, there was a decline in the systematic screening of patients that were attending outpatient department. Next slide. So the NTLP came up with an algorithm that was trying to integrate screening for both diseases, but we saw that this algorithm had not been tested in the real clinical world, and at the same time, the algorithm was not proactively looking out for screening of COVID suspects for TB. Next slide. So that is the algorithm that was initially rolled out by the NTLP, and that circle in red is where they said that if somebody is a COVID suspect, you would follow the COVID-19 management guidelines as per Ministry of Health. Next slide. So next slide, please. The study objectives, the first one was to really explore the perspectives of the health providers at Chirud National Hospital and what they think about integrating screening for both diseases. Then the next objective was to determine the effect of the COVID-19 algorithm on TB case identification, and finally to also evaluate the effect of a modified TB screening algorithm that included mandatory TB screening for COVID-19 suspects. Next slide. So that is how we answered objective 1. Next slide. And that's how we answered the objective 2 and 3. Next slide, please. Next slide. So we utilized implementation science methods, and we used what we call the COMBI model, and this looks at that the behavior is really influenced by the capability, that is the knowledge and skills, the opportunity, that is the physical tools, and also the motivation to conduct that behavior. So that is the model we use to be able to answer this question of objective 1. Next slide. Next slide, please. I will not go much into the barriers and facilitators. Next slide. So that is how we address the different barriers and facilitators that we identified. To address inadequate knowledge, we trained the healthcare providers, and also to address issues around availability of SOPs and tools, we provided them, and also supplied them with some PPE to be able to build their confidence, to be able to screen these patients, since we found out that there was some inconsistent supply of the PPE. Next slide. Next slide. So that is the important thing that we found out, that we screened 1,464, and we realized that those who were COVID suspects were 1,252, and we went ahead and actually screened the COVID suspects, screened them for TB, and we see that 717 of them actually screened for positive on a symptom screen of TB as well. And when we tested them, we see that 104 of them actually turned out to have TB. And on the other side, if we had followed the algorithm as it was initially formulated, would only be managed to identify 6 people with TB. Next slide. So what this showed us is that proactively screening COVID-19 suspects actually contributed to 94.5% of the 110 newly diagnosed cases that we were able to capture during the study period. Next slide. So this is what we did. After these studies were shared with the NTLP Research Forum, we also presented to the MOH COVID-19 case management pillar, and also presented these results at the Union Conference. And this informed the revision of the algorithm. Next slide. And that's the new algorithm, which was informed by the results of this study. And as we can see in the new algorithm, we see that there is integrated screening of COVID-19 and TB in the same patient. The samples are collected at the same time, and the patient is tested for both COVID-19 and TB. Next slide. So what we have learned is that so much can be achieved if there is collaboration between service providers, policymakers, and research scientists to be able to evaluate and scale up evidence-based interventions. Next slide. Yes, that is the study team, and as you can see, it was a stakeholder team, and we have people from Mackay University, the NTLP, and also from Chirudu National Referral Hospital. Thank you very much.
Thank you so much, Daktari. On behalf of the research team, I think the take-home message is very clear. The IT team, do we have the presentation for Dr. Eric ready, or we invite someone physically present? Dr. Wazanye, do you want to step up? So again, the guidance is 5 minutes. We have put someone to guide your pace. So look at her, the young, beautiful lady with the pink mask.
Good afternoon. As the Lord my presentation, I would like to recognize in a special way those who are 75 years and older. There was no TB treatment 75 years ago until October 1944 when paramagnetic salicylic acid and streptomycin were introduced as the first TB drugs. And by 1980, we had a regimen that was lasting for 6 months. So the current 6-month regimen has been with us.
Dr. Wazanya, I think, is your slide ready?
Yeah, I'm just waiting for that as I give a preamble.
Okay, there you are.
Right, so since 1980, we've been having this 6-month regimen. This more than 40 years ago. There's been lots of research that has been ongoing, looking for new compounds, new drugs to shorten TB treatment to less than 6 a month, but this has been very frustrating. There's been no success. Please, I'm not seeing my slides.
So that's the wrong slide. I think just hold it a bit. I know we are pressed on time, but so that you don't lose the audience, especially those online.
Yeah, I'm speaking on behalf of Professor Harriet Mayanja. We both from Uganda Case Research Collaboration.
The IT team.
Yeah. So I'm just waiting for the IT team to upload my presentation.
We'll give you some 2 minutes for the mishap.
Okay. All right, so this frustration has been ongoing for more than 40 years, as mentioned already. And then came the year 2016, the TB Trials Consortium of the U.S. Center for Disease Control and Prevention designed and conducted a multi-center international open-label randomized trial of non-infected design, looking at high-dose rifampicin with or without moxifloxacin for the treatment shortening of tuberculosis. Next slide.
I think you hold a bit until it is loaded. Don't worry, we shall give you some time to cater for the mishap. IT, look for the presentation.
It looks like the technology has been disobeying me. Okay, as we wait for the slide, so I didn't mention so we had the TB Trials Consortium study 31, and this had 3 regimens. We had the standard regimen, which is the 6-month regimen, and then 2 experimental regimens, and each was being given for a total of 4 months. And as I earlier mentioned, the slides are not coming.
Beatrice, can you help us upload Professor Harriet Mayanja's slides which are looking at the study results for a 4-month anti-TB regimen with 2 new drugs. Thank you.
So we are in this room because of one main objective. We came here because we are fighting TB. And as I mentioned earlier, this war has been going on for the last 75 years, but we're still fighting the same war. Okay, so next slide. We've already spoken about the current slide. All right, so the main background to this is that there's been lots of frustration. So we, the scientists in the TB Trials Consortium, thought, how about if we optimize the use of the current existing drugs, and that's rifamycins and also the quinolones. And then there was a program that reinitiated the development of rifampicin way back in 2000. They did preclinical and RFS clinical trials, and the accumulating data from these studies did show promise regarding TB treatment shortening. Next slide. All right, so we had two main objectives. The first objective was like, if we do a single substitution where we replace rifampicin with rifampicin, can we be able to shorten TB treatment from the current 6 months down to 4 months? And then objective number 2 was a double substitution. If we do double substitution where we replace rifampin and ethambutol with rifampicin and moxifloxacin, can we be able to shorten TB treatment from 6 to 4 months? Next slide. So that was the study schema in summary. We had the control regimen, which is the standard 6-month regimen, and then the other 2 experimental regimens, single substitution of rifampicin, replacing rifampin, and then double substitution whereby rifampicin and moxifloxacin did substitute for rifampin and ethambutol. Next slide. So our outcomes, our primary outcome was being free of TB disease 12 months from the time you enrolled in the study, and the secondary outcome was being free of TB disease 18 months from the time you enrolled in the study. And we classified our outcomes as being either unfavorable outcomes, favorable outcome, or being not accessible. Next slide. So this was a multi-center international study in 13 countries, making a total of 34 international clinical sites, with sites in Africa, Asia, Europe, and North and South America. Next slide. So this is the study profile. We screened more than 5,000 patients and ended up randomizing more than 2,500 patients. And you can see distribution of participants across all the 3 study arms being more or less the same. We initially excluded patients for microbiological reasons, and then we end up what we call the microbiologically eligible population. Then we further excluded patients again for different reasons like loss to follow-up or drug toxicities. Then we end up what we call the accessible population. And all these populations ensure the equal distribution of patients across all the study arms. Next slide. So this is showing recruitment by country. You can see Uganda and South Africa were the lead enrolling countries in this consortium, and then the other countries followed suit. Next slide. Now this is a table of baseline characteristics of the microbiologically eligible population. You can see men dominated the picture of the patients who enrolled in the study. There were more black people than any other race. Only about 8% of our patients were HIV positive, and majority of our patients had cavitation on X-ray. Next slide. So this is showing the primary outcome results when we compare the double substitution regimen, the rifampicin mox regimen compared to the control. So we have the 2 populations, as you can see, the accessible population and the microbiologically eligible population, as you can see over there. Now, for all the 4 comparisons, as you can see, our non-inferiority margin was 6.6%. The upper limit of the 95% confidence interval, as you see over there, is below the non-inferiority margin of 6.6%. And this leads us to a conclusion of the rifampicin mox substitution regimen meeting non-inferiority. Next slide. Now, how about the rifampicin alone regimen compared to the control? You can see the upper limits of the 95% confidence intervals either equal to or above the 6.6 non-inferiority margin, and this leads us to a conclusion that the rifampicin alone single substitute regimen did not meet non-inferiority criteria. Next slide. All right, so about the secondary endpoint. So the secondary endpoint was being free of TB disease 18 months from the time you enrolled into the study, so almost 2 years from the time you enrolled into the study, okay? So we did our analysis. We did accessible microbiologically eligible population, intention to treat, and then protocol correct analysis. The upper limit of the 95% confidence interval is still below the non-inferiority margin of 6.6%, and that means this regimen still retains non-inferiority. Whereas when it comes to the rifampicin alone regimen, you can see it gets it gets inferior. As you can see, the upper limits of the 95% confidence interval are above the non-inferiority margin of 6.6%. Next slide. Next slide. Okay, so when you're doing a study, you tend to look into different subgroups and possible confounders and find out if the drug would do well as well in those subgroups. There are key subgroups in TB like HIV, cavitation, bacillus burden. So the p-values you're seeing here are p-values of interaction in each subgroup, And you can see for the rifampicin MOX regimen, all these p-values are insignificant, and that means still you retain non-inferiority with regard to this regimen. Next slide. Now, when it came to looking at the rifampicin regimen in subgroup analysis and sensitivity analysis, we have some interesting findings in select populations, beginning with the bacillary burden, for example, or cavitation rather. I would say patients who had no cavities did well with the rifampicin regimen, whereas they did do worse with a control. And when you cross over to cavitation, those that had cavitation actually did better with the control regimen compared to the rifampicin regimen. And the other findings were the smear grade. Patients who had low smear grade from negative scante through 1+ did well with the rifampicin regimen, but when you cross over to 2+ and 3+, you can see that the control regimen does better than the rifampicin regimen. And then the other important finding was patients who grew TB quickly on midget, okay, did very well with the control regimen compared to the rifampicin regimen, but whereas those who took longer to grow TB on midget, didn't do well with
Moses,
control
I think
regimen.
you need to transition to closure.
Right, so when you do a study, you need to find out how safe is this drug as well. The mind shouldn't be alone on how efficacious this drug is. So we did all the safety analysis regarding the experimental regimens compared to control. And in summary, I can summarize and say that the experimental regimens were found to be safe in these patients who enrolled in the study. Next slide, next slide. All right, so we had an adolescent population, about 6 to 8 patients randomized, among those randomized in the study, and this more or less equates to the pediatric population of patients in the study. And these drugs were as well found to be safe in this population. Next. And regarding efficacy as well, these drugs were found to be efficacious as well in this population of patients. Next. How about the HIV positive people? The drugs were found to be safe as well as efficacious in this population of patients. Next slide. All right, so we need to come and summarize this up. For the rifampicin moxifloxacin dose substitution regimen, non-inferiority was met in all the subgroup and sensitivity analysis that we did, and the data is robust. Whereas for the rifampicin regimen, non-inferiority was not met across overall, though for a select population, like those having the low bacillary burden, no cavitation on X-ray, and those who took longer to grow TB on midget, it was found to be non-inferior to the standard regimen. Next slide. So this is an excerpt of the publication in the New England Journal of Medicine. So the main manuscript has been submitted and published in the New England Journal of Medicine. Next slide. So my last comment is that these results have been endorsed by WHO, and they are recommending the countries to take up this new 4-month regimen. So at last we've been able to find a regimen that can shorten TB treatment from the current 6 months down to 4 months. Thank you for your attention. Now, welcome your questions.
Thank you, Moses. I think here this is a clear demonstration of Uganda's contribution to the global guidance and norms on TB prevention and care. So kudos to the research team and research agenda. Thank you. IT, can we have the presentation by Dr. Eric set up? And then we shall have Professor Achilles and Christine coming thereafter.
Okay, okay, Professor Chilis Katamba, you can come and make your presentation, as Eric's will be sent on our email, Eric's presentation. So, thank you very much, Professor Chilis Katamba. Over to you. You can upload his slides.
I will start with a disclaimer that I'm not yet a professor. And so, but thanks for the good wishes. I'm still a senior lecturer. So,
Received.
Yeah.
And we pray for the achievement of that desired title soon. Thank you. You're welcome.
I'm just going to quickly take you through utilization of digital technologies for TB prevention and care in Africa. The digital adherence technology in Africa, implementation of that in Uganda, and some concluding remarks. So, what's happening with the technology? Okay. So you can see the number of countries which are implementing digital adherence technology. And most of these have been mainly funded by some Stop TB partnerships and others, mainly donor to test them out. However, as you can see from that slide, implementing different types of digital adherence technology, 99 dots, video dots, and other types. But I want to focus on Uganda in particular, which is implementing digital adherence technology for both DSTB and MDR-TB patients, contacts, prophylaxis, there is a study going on, and also for HIV patients. Here there is a 3HP trial which is going on with MJAP, and Dr. Semitara is involved in that. So telling you about 99 dots in Uganda in particular, a number of partners, as you can see, this was supported by Stop TB partnership. And in this trial, actually, we went to determine whether 99 dots intervention improves TB treatment outcome. And our focus of outcome was proportion treated successfully, persistence on TB treatment, and loss to follow-up. And we also looked at who did we reach really. Some people we did not reach them because they did not have phones and other things, which is important to put into consideration. We are not going to look at cost now, but we did the costing and shared it with implementing partners, what it means to. We did implement this study in 18 facilities, 15 hospitals and 3 centers. And those, the map of Uganda shows where they are distributed. And this was more of feasibility since it was a study. We couldn't go everywhere in Uganda. What did we find? When we looked at who was treated successfully, we found that actually, for those people who got the intervention, because some did not get it, we found that they were almost 3 times more likely to be treated successfully, 86.6% as compared to 72%, which is more of the intention to treat if you include those who did not get it and also analyze their outcomes. When we looked at issues of people who completed intensive phase, really, we found that people who got digital adherence technology were almost 4 times more likely, 91.4% as compared to 81%, really to complete intensive phase 2 months. And loss to follow-up, we found that loss to follow-up of those people who got digital adherence technology was as low as 3.2% as compared to 12.5%. One thing, whom did we reach? Among all the people we intended to reach, we only reached 52%. And the major reason for not reaching those 428 was really a lack of access to a phone. And we think that our people have phones out there. However, not everyone has a phone as we think. So it is an important consideration to put into consideration when you are trying to make. The key message for the trial, we found that 99 dots was a viable alternative for either community-based dot or facility-based DOT. But increasing access to 99 dot is a key consideration for scale-up. Lack of access to a phone is a primary barrier. And you can put into consideration a cost of about $10 per phone. So we asked the Stop TB Partnership to give us money to scale up. And this time we asked them that, please, let's buy phones as a cost. And that was done. So we provided phones to our people, whoever did not have a phone at those 30 facilities. And what did we find? We found that from 52% of people who access this service, in the scale up to 80% already. And this is preliminary results. There may be more. And so we realized that also, in terms of looked at the data for 85% had already accessed the phone. So access to a phone is important as we think of scaling up digital adherence technologies. In my concluding remarks, I want to say that COVID has presented us with many challenges, but also many opportunities, particularly on how to care and service for TB and across diseases is accessed by all people, including the most marginalized and delivered by providers. We need to seize these opportunities now and reimagine TB care by making it convenient and easy as possible to people to access people-centered, differentiated, and integrated care and service based on their daily lives and needs and wants. Bring this care and service beyond the facility level to people, neighborhood, and doorsteps, as one of our DCs from Wakiso said. One way to do this, we need to leverage digital technologies and strengthen the ICT infrastructure in the TB-affected countries like ours. As Uganda TB Implementation Research Consortium, WALIM, together with Ministry of Health and NTLP, we have been working hand in hand with Stop TB Partnership on this journey to reimagine TB care in Uganda and in the future. UTAC, together with WALIM and NTLP and Everwell, we responded to a request for proposals for reimagining TB care from the Stop TB Partnership. Here is strengthen digital ecosystem and infrastructure for TB by integrating a diagnostic and adherence module into the electronic-based, case-based system of Ministry of Health, which does not have an adherence module. An adherence module is the digital adherence technology 99 dots. We want to integrate it within that, but we also integrate a digital adherence issue. And as you heard yesterday from the executive director from GUN, it looks like our request for proposal is going to be funded, and we are going to integrate that. So that brings me to the end of my presentation. Thank you for listening.
Thank you very much, Professor Katamba. Continue the great work in research that you are doing that is informing us in programming. I would like to use this opportunity to welcome our Director, Public Health, Dr. Daniel. I'm very honored to see you here. Thank you for coming. We'd also like to recognize the presence of USID, Dr. Patrick Ajuna. You're welcome as well. And we also want to recognize our past program managers. The first program manager of the National TB and Leprosy Program, Dr. Peter Eriki. You are, once again, we always are honored to have you. And Dr. Adatu Francis. At times we call them Wazee Wakazi. Those are the people who have moved the program to where it is today. So we are really grateful to have you. Okay, we have Dr. Eric over there. If you are around, please come and make your presentation. It's online? Okay.
Yeah, good morning, everyone. I hope everyone can hear me.
Good afternoon. Go ahead.
Okay.
You have 5 minutes, Eric. Dr. Eric, we can't hear you, please. Okay. Okay. I think as you try to get him online, let's go to Christine. Dr. Christine, come and make your thank you. Dr. Christine, make your presentation. Dr. Wobdea, we shall get back to you. It seems we can't hear you, and time is not an ally today. So, Dr. Christine, go ahead. Upload her presentation, please.
Thank you, Mr. Chairman. I'll wait for the slides to be uploaded. Okay. I'll skip some slides. Next slide, please. Next slide. So we know that about 40% of our patients go to private sector to seek care before they actually get diagnosed with TB. Next slide. And to increase the number of case notification from private sector, in Kampala, Wachiso, we had the following interventions. Next slide. We trained private pharmacies, the staff in private pharmacies, to screen patients for TB using our standard tools. They collected sputum. We also trained community health workers to go door to door and using outreaches to do the same. They used our standard tools and collected sputum. And then this sputum was collected at central places, the pharmacies, either through the community workers going to the pharmacies and leaving the samples there, or directly picking from the community health workers using the hub and spoke. We leveraged the existing Defeat TB hub riders and our own to pick the samples and transport them to the centers where GeneXpert is performed, including IDI, Mulago, Uganda Cares, and some of the KCCA sites. We also used an SMS system to revert results to the health provider and also the patients, and also conducted contact tracing through the community health workers. Next slide, please. Next slide. Our key outputs, we screened about 130,000 patients for TB, although we had targeted a higher number, but we managed to test higher than we expected. We tested GeneXpert, using GeneXpert, we tested 10,000 patients. We diagnosed for about 430 with TB, and through contact screening, we diagnosed an additional 15 patients with TB. Next slide. So after this, we chose to evaluate our whole project to see the effect on decreasing time to diagnosis and time to receiving TB treatment, and also to understand if the community pharmacies were willing, how they experienced this intervention. Next slide. So we enrolled 325 patients, either from the community health workers, diagnosed through the community health workers, the public facilities around that same time, and then also our pharmacies that were involved. Next slide. So these are our findings. We found that those who are diagnosed in the pharmacies and those who are diagnosed from the public facilities, these were Chiswa and Entebbe hospitals, took about the same time from onset of symptoms to the first contact with health worker. But those who were diagnosed by the community health workers took about 60 days from the onset of their symptoms up to the time that they got contact with a health worker. Next slide. When it came to time between the days between TB diagnosis and actually starting treatment, the ones in the public facilities took about 1 day. Previous slide. Previous slide. The ones who were in the public health facilities took about 1 day to start treatment from when they were diagnosed, but those from the pharmacies and community took about a week to start their treatment. Next slide. Like previous slide. Okay. Then the total time between onset of symptoms, from when the patient felt their symptoms up to the time they started treatment, was lower with the public facilities, then the pharmacies, and then longest with the community health workers. And this kind of reflected the kind of patients that are found in the communities. They're usually sicker and probably are not accessing their health facilities. Next slide. When we looked at the costs, the cheapest intervention, of course, was using the community health workers. With about $6, the patients spent about $6 before they got their TB treatment. Those in public and private facilities, the cost did not differ, although the ones in public facilities were slightly higher. Next slide. Next slide. So looking at the private provider perspectives, we're looking at the plus side first. Individual experiences. The pharmacists felt that this intervention kind of increased the number of people who came to their pharmacies, and people actually referred other people to them for screening. So they were excited about that part. They were also excited to be able to serve the community and happy that the samples were actually collected on time, and they received support when it came to linking the patients to care. Next slide. But the challenges they had, it was sometimes difficult to convince patients to provide sputum samples, especially during COVID, because there was a time where they thought if they were diagnosed with COVID, they would go into quarantine. They were also afraid of the exposure they themselves had to COVID. We also had, but they had a loss to follow-up of patients, and it was quite time-consuming because of the documentation using our standard tools. At the facility, they had problems of space, change in management, and then you have to explain everything again, and then not collecting sputum samples over the weekend. Next slide. Patient-related challenges. Patients who were diagnosed in the pharmacies did not want to go to public facilities to receive treatment, and sometimes even provided incomplete information because they didn't want to be found. However, the pharmacists themselves were motivated because they had an incentive, financial incentive, for every person they screened and every person they diagnosed positive. And they were also, the patients were happy because we gave them transport from when they were diagnosed to receive treatment. So in conclusion, next slide. Involvement of these pharmacies and community health workers, which was a blended intervention, actually increased our case finding. We found that it's feasible and can contribute to increased case finding. Although the time to treatment initiation was not shortened, we do add to our numbers and the reach of patients. We also found that it's cheaper to the patient to use community health workers, and the community health workers will find the patients who don't want to come to hospital and who are really sick. Use of the community workers may increase access to those who are silently suffering in the communities. However, we need to first address the challenges faced by the private providers engaged in screening. For example, it might be useful to give them access to treatment so that they can reduce the time between when they diagnose and when they start patients of treatment, and also to continuously provide transport services regardless of project interventions, regardless of weekends and public holidays. Thank you very much.
Thank you,
Can
Christine.
put up the acknowledgement slide for the sake of the funders.
It's a very important slide, that one.
The last slide, acknowledgements.
Acknowledgement. Okay, it's gone off, but I appreciate. So thank you for your perspectives. This speaks directly to our planned national cost intervention, and so it is a very well-received piece of work. Can we try Dr. Eric once more? As Jimmy Sewanyana sets up. All the presenters have gone behind. I don't know if you could count.
Mr. Chair, Eric, I'm online.
You're back, okay. Please go ahead. I hope you have stable connection. We are all ears for you. 5 minutes, yes.
Okay, thank you very much for inviting us to make a presentation. I'm presenting on behalf of my co-PI, Adam Atakatamanchi, on our interim results on the evaluation of urine TB lab and as stool gene expert for the diagnosis of TB in children. As a background, we know that diagnosis of TB in children remains a challenge, because of the non-specific symptoms and prolonged cough and failure to thrive, and also complicated by the bacillary nature of the sputum, which decreases the sensitivity to most of the tests. This is further compounded by the difficulty in collecting sputum. And for this reason, non-sputum-based biomarker tests for diagnosis of TB in children are becoming more and more important. In this presentation, I'll basically be presenting some of our results on the urine lamp and the stool expert ultra testing for the diagnosis of TB in children. Our urine lamp, you know, the lamp is basically an antigen of the TB which is excreted in the urine. The current lamp that we know, the allele form, really performs poorly in children, and these concentrations are quite very low in children compared to adults. There is a more recent generation, next generation lamp test, which we call Fujilam or the Silvamp TB lamp, which seems to have showed much higher sensitivity in adults. And so we wanted to evaluate this in children. We also know that furthermore, the stool is also a promising test, a promising sample in children because children swallow most of their sputum. Though it has a big challenge of having PCR inhibitors that actually eventually cause a lot of indeterminate tests. There are a number of groups that are developing centrifuge-free methods for stool testing. In our study, we worked with FIND and we were testing a stool processing kit, which is centrifuge-free, and be able to use it for testing for stool and for TB in student children. Our study objective was really to be able to evaluate the performance of these tests for rapid diagnosis of children, of TB in children. This was a prospective diagnostic accuracy test, and we conducted this in Mulago Hospital, in some of the KCC facilities in Kampala. And our study population mainly children under 15 years with symptoms of PTB. And they should not have been on prophylaxis for TB treatment the last 1 year, and we excluded those that could not provide for us as respiratory, urine, or a stool sample. The test that we used, the index test that we used was Silvamp test, which is the Fujilam, and the lateral flow, which is determining TB lamp, and also the SPK ultra. In our reference tests, many we did 2 reference tests. The first one was the TB confirmation, so in which we confirmed TB on expert, or solid culture, or liquid media. And then the other reference test was the consensus, the NIH consensus definition, which defines our patients into confirmed, unconfirmed, or unlikely. And in terms of analysis, we basically looked at sensitivity and specificity, and we're comparing the confirmed versus the unlikely TBs. And also we tried to evaluate the added yield of this test in the unconfirmed TB cases. This is a picture of how the TB Fujilam looks like. I will not go through the details, but as you can see, this kind of is a straightforward test whereby you pick a sample and you put it on the cartridge, and this has been enriched to be able to visualize with silver molecules. And then for the stool, again, it's another straightforward process whereby we get the stool sample. This is the fine stool processing kit, and we get the stool sample put in a container with the reagents. This is really shaken and kept for like 30 minutes, and then you apply the filter on the top like a cover, and then you'll be able to express that in the Gene Expert cartridge, and you'll be able to test for TB in the children. Now these are some of the results, quick ones. So we looked at, for urine lamp results, we had 151 children that we looked at, that the results that we have, and the median age was 4 years, 48% were male, 11% were HIV positive. We see that half of them were actually underweight, 14% of them were hospitalized, and we had 13% provided for us urine in the bag. 40 of the children had unconfirmed TB. Had confirmed TB, and 57, which represented about 30%, were unconfirmed, while 36% were unlikely TB. And then, so in terms of other results, so if you look at sensitivity, we compare the confirmed versus the unlikely. And looking at sensitivity of urine lamp, the Fujilam compared to the lateral flow, the one that we usually use, you can see the sensitivity, there's a big difference. Sensitivity is still low, but it is higher in the Fujilam at 50% compared to 20% at the lateral flow. And that difference was quite significant for 30%, the p-value of 0.001. And the specificity was 88% in the Fujilam and 96% in the lateral flow. However, that difference was not statistically significant. So it was different in terms of the sensitivity of this test. When looking at the unconfirmed cases, they did not add us very much. Only like 23% were actually positive with the Fujilam, and 17% were positive with lateral flow. So these were kind of the children that were missed, but they were positive. So these would be either false positives or, so these are some tests we are still to understand these results. Looking at the stool results, we looked at 153 children that were analyzed. The age was basically similar, even the sex distribution, and the HIV positivity about 12% or similar. Slightly higher children who were underweight, 60%, 40% had diarrhea, and in this population, 40 of the children had confirmed TB. Looking at the results, now these are results compared looking at the SPK, and we see that the sensitivity of the SPK was 42% and the specificity was 98%. So we had 14 children who had invalid results, and this reduced 3 when we did the repeat test. And there were no additional yield on repeat testing. No children with unconfirmed TB had a positive result. So this is what we see in terms of diagnosis accuracy for SPK, still quite low in terms of sensitivity. But when you try to look at it compared again to what we have, now if you compare the SPK, the sensitivity is 58%. If you compare compared to sputum testing. So this compares sputum testing, and the specificity of 97% there. So if you look at the sputum smear, which is 50%, and the difference in sensitivity with the SPK of 8.3%, which was not quite significant. And then we also looked at the sputum expert. You see the difference is 12 in terms of increased numbers there. By and large, what this is trying to tell us is that we see that the stool expert stool is better than the smear in terms of finding cases and with good specificity, if you have an alternative to sputum smear. In conclusion, we see that the Fujilam had superior sensitivity to lateral flow for pulmonary TB. The LAM is promising, non-invasive biomarker test, but probably we need further efforts to improve its sensitivity. The SPK Ultra, which is for stool, detected almost half of the children confirmed TB. And we observe a key thing there that although the SPK had lower sensitivity than Ultra, it had better sensitivity than smear microscopy. Looking at some further ideas about our study, we know that we had some strengths and weaknesses. It's prospective, that was a strength, and we recruited patients from really various populations. We were limited because we had fewer children with HIV, and we could not rule out other prominent sources of TB. Nevertheless, we still feel that since most of our children had respiratory symptoms, and we had a primary reference as confirmed cases, we still have some valid results here to be able to present in terms of improving diagnosis in children. So the implications for this is that SPK and Fujilam may be useful when sputum collection is not feasible for TB diagnosis in children. Implementation research, especially Fujilam in lower health facilities, is needed to know how it operates there. And then SPK has demonstrated high feasibility. And so this by removing the centrifuging part. The last two statements, you can first of all ignore those. And I want to appreciate and acknowledge all my other co-investigators and who have been part of this work. And also I appreciate all the investigators in Uganda, our funders, the NIH, the FIND team that we worked with, and all the study team at Mulago, headed by Dr. Peter Wambi. Thank you very much for listening to me.
Thank you. Thank you very much, Dr. Eric, for that good presentation as we look at alternative ways of diagnosing TB in children. Can we now call upon the last presenter, Dr. Jimmy, who is going to talk about TB mortality audit results, a study from Lira Regional Referral Hospital. Over to you, Jimmy.
Yes, protocol observed.
5 minutes.
Waiting for my presentation slides. I'm Dr. Jimmy Sowanyana, head of TB services at Lira Regional Referral Hospital. In Lira Regional Referral Hospital, from the period of June to September, we noted that we're reporting a number of, we're registering a number of deaths, which prompted us to conduct an audit to determine what are the contributing factors to this death. Out of 150 clients, this is not the presentation. Okay, out of 150 clients, 123 were for DSTB, and the 27 were from the MDR-TB side. 12 cases were registered out of 150, and amongst the 12, we had 7 who were female and 10 who were male. And on top of that, 6 were from the MDR-TB side, and the 11 were from the drug-susceptible TB. On top of that, we also noted that amongst these 12, 11 clients were HIV positive and 6 clients were HIV negative. In regard to the age, we also realized that most of the age group that was being affected, these were people who were between 35 to 39 years, and followed by advanced group of 55 years and above. Which groups we need to really do what? We really need to follow up why the death was amongst those groups. I've done the summary of that. After doing our audit, these are some of the findings that we came up to. Some of the findings from our audits, we realized that COVID was one of the contributing factors, and COVID had a percentage of 17. Severe acute malnutrition had a percentage of 29%, CCM 12%, and anemia 12%. I don't know whether the thing is moving where I want. It's just going back.
Do you want to come and
Okay.
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 All right.
These are some of the clinical findings. Actually, the main reason why I'm here, I want to let you know that our patients, as we are doing our best to manage, other things are killing them. And these are some of the possible causes of the death in our patients. As you can see, I looked at the immediate causes and the underlying causes. I looked at the immediate causes and underlying causes. Among the immediate causes, we have immune suppression due to advanced HIV disease, and most especially we looked at CCM and TB meningitis, COVID-19, as I mentioned earlier, sepsis, and iris. Underlying causes, we had liver disease, disseminated TB, aspiration pneumonia, anemia, malignancy, and other causes. We had other contributing factors. We had other contributing factors, and these included most of our clients, actually, all of them who died, there were 17, the total. All of them, they had a late health-seeking behavior to treatment. What does it mean? Most of our clients came when they were really in a severe immune state, whereby even when we could do anything, still they had a very poor prognosis. And most of these clients, 92%, they died within 8 days of admission in the hospital. And most of them, they were on their second month of treatment initiation. Recommendations in regard to this. After we knowing that, yes, these were the problems which were contributing to the deaths of our patients, what did we recommend? Actually, we strengthened and integrated screening for COVID-19 and advanced HIV disease, both at OPD and IPD, As I'm speaking right now, our death rate has reduced from 17 now to 4. For this quarter, we have only lost 4 cases, meaning that the integration really supported us by identifying COVID-19 in our patients as early as possible, and we were treated. Community engagement through SBCC for improved health-seeking behaviors, strengthened healthcare capacity, in other words, capacity building for the peripheral facilities, encourage of interdisciplinary management of TB patients, proper and thorough patient evaluation, counseling about adherence and side effects, strengthen social support system for patients, provision of enablers to DSTB admitted patients. Most of the death is on the drug susceptible patients side, reason being they're not well supported. Much support goes to MDR TB patients. We really need to support these people because some even deny to take the drugs saying they don't have anything to eat. How do we expect them to take the medicine yet they don't have anything to eat? I would like to conclude by stating that most deaths of patients on TB treatment happen within the initial stages of treatment due to underlying life-threatening comorbidities that worsen the patient's clinical condition and prolong hospitalization. Strengthen inpatient screening and repeat screening of patients admitted from outpatient department. Emphasize the availability, feasibility, and accessibility of baseline investigations. Scale up TPT for TB prevention among HIV-positive clients. This one need to help us to combat death in TB clients. Much appreciation to Ministry of Health, USAID Rights North Lango Project, USAID Defeat, and Global Fund. Thank you very much. God bless you.
Thank you, thank you. Another round of applause for Jimmy, Dr. Jimmy. When we started, there was a caveat that the director, Dr. Charles, said that it's going to be difficult chairing this session in the time. But we want to thank all the presenters, and we want to let the audience know that there's a lot of research going on beyond what you've seen, and there are a lot of research findings that are making the program do what they are doing. Just because of time, I will allow only 3 very critical questions or comments. If there are any 3 to any of the presenters that were there, if you noted a question. Achilles. Do we have any questions online? Okay. So it is going to be only Professor Katamba. Thank you. Over to you, Katamba.
Yeah, my question goes to Simon, who presented about IGRA. And from his findings, he's recommending that we screen patients using IGRA. However, looking at the data that is available as far as IGRA is concerned, about 2 to 4% of the patients who are IGRA positive, and that is similarly for TST, will progress to develop TB, those contacts. And we see that data from studies show that you need to treat 25, maybe to 50 patients, on average 37 patients, to just prevent one episode of TB, which might not be very cost effective. I wonder, given that we don't have good predictors of who will develop TB, whether the recommendation to screen people may be cost effective given the resources that have to go in and the usefulness of IGRA and TST in predicting TB. We know there are new biomarkers being tested, like PREDICT3, CRP, and even hemoglobin through EDCTP, trying to say how can we really predict who develops TB among the contacts. We know most people will never develop TB.
Simon, please respond. and then we'll close the session.
Yeah, thank you, Achilles, for the question. That's an important question, and I don't know why you ask the difficult questions. But essentially what you're saying is that we need to do more. We need to come up with a test that can help us predict who of those with latent infection will develop TB disease. And there's some work going in that direction. Yeah, but my recommendation is based on a public health approach. In terms of the cost effectiveness, I think someone mentioned here yesterday that the cost of a diagnosis of a patient using a gene expert is around $80, okay? And if we are to treat 37 patients times maybe isoniazid, which is about $0.6, certainly 37 patients with about a cost of IPT, which is about $0.6, just using that simple math, not going into the complicated cost effectiveness math, it might be cheaper to provide TPT rather than going through the process of screening, evaluating for TB disease, say using gene expert, and going through the treatment and so on and so forth. But also, you're just looking at program costs. You're not looking at costs to the patient and to the family. You know that there are catastrophic costs to 53% of the families. In English, not in TB, that is about 53 out of 100 families spend more than 20% of their annual income on finding a diagnosis and going through the process of treatment of TB. So we need to look at the costs to the families and to the patients. We need to look at issues of mortality, so death in simple English. So those are costs that we need to consider. And then now that we are going multi-sectoral,
can you conclude, please?
The economists can also tell us, yesterday they said for every dollar invested in TB, we gain, I don't remember how many dollars. So there are other losses that the country incurs when people are sick with TB disease. So I hope, Achilles, I'm able to convince you that preventing TB through preventive treatment is a worthwhile investment. Thank you.
Thank you very much. Thank you very much, Simon. That's our prevention guru. Ladies and gentlemen, I want to take this opportunity to thank you. Public health interventions continue to become important, and prevention is better than cure. We look forward to more research questions that we need to answer as we continue to towards ending TB by 2030. I want to thank you for being a very good audience. I want to thank you for staying awake as we go into the closing ceremony. I will now kindly request, who is our MC? We shall call upon the Assistant Commissioner to guide us, but I am very much aware our Director of Public Health is going to be in the chair in the next few minutes. We welcome you and the Assistant Commissioner. Thank you very much, and have a nice afternoon. Thank you.
Okay. Thank you, the outgoing chair and co-chair, and the MC for today, our beloved champion for TB and leprosy, the cow of now Boyukwe. We have come to the end of our conference, and we are going into the closing ceremony. Our chief guest for today, the Honorable Minister of Health, represented by the Director Public Health. And we have covered the 2 days activity. I want to request that in honor of what we have achieved, we stand up and shake our bodies to make the blood flow. I will not ask you to clap your hands. Stand up as I request the next chair or presiding office, the Director Clinical, to come and guide us on the closing ceremony that we are going to have. So keep standing as the chair is coming to guide us on the closing ceremony.
Okay, thank you, Stavia. You can continue standing, but also you can have the other option of sitting. So let's be seated, I think. So we're going to go through the closing ceremony, and I want to take this opportunity to recognize the presence of the representative of the Honorable Minister in the House. So let's put our hands together to welcome Dr. Daniel Kabayiza, the Director of Public Health of the Ministry of Health, who is going to be our guest of honor in the closing ceremony. I would like to invite Dr. Abel Nkolo, the implementing partner, who is going to be making closing remarks on behalf of the implementing partners. The chairperson of the DHOs to join the guest of honor on the podium. And Dr. Peter Lochoro making remarks on behalf of the civil society organizations. And at the same aspect, I also want to put on notice that those who are responsible for certificates and appreciation, you make them ready so that we will have the guests of honor give out the certificates and make his closing remarks. Our presentation is loaded. You reading the communique. Do we have any representative for the DHOs? I know the chair, yeah, would want the representative of the DHOs to come forward. Look like the time which had been paid for the chairman had expired. So let me ask at this point in time to invite Peter. Really would want to make this closing ceremony short, so please take less than 5 minutes to read the communique, and then we'll have Abel speak on behalf of the implementing partners.
IT, can you load it? Can you get it?
I want to take to the members that your late lunch is not caused by the chair. I think the circumstances beyond the chair. But nevertheless, I want to assure you that the lunch is there.
We send you the key highlights.
So don't leave it. It's late, but you have it before you depart. I think the presentation has already now been loaded, so the communique.
Okay. I was told to do key lights for the National TB and Leprosy Stakeholders Conference, Day 1 and 2. And I want to recognize Moses Odongo, who was a rapporteur with me. There's a Jambo Priscilla, who is not here with us. And of course, myself. As you can see, the IT is taking their time, but we had distinguished guests, the permanent secretary who was represented by the DG himself, the CSO representative, the executive director of Global Stop TB Partnership, Global Fund Geneva country team coordinator, the US ambassador who was represented by the CDC country representative, the WHO representative, and of course our distinguished guest, the Honorable Minister of Health. Other invited guests were the MP, the MPs, the chief administrative officers, the DHOs, and of course all of us who are here. The key highlights, next slide. The theme was accelerating program towards the 2021 United Nations high-level meeting, targets in the COVID-19 era, for meaningful involvement in TB response and decisive and accountable leadership in TB should be provided for the TB affected. USTB promised to look for avenues of raising resources to address the 35% funding gap with support of Global Fund organization. Global Fund is committed to supporting country HIV, malaria, and TB programs in reaching the UNHLM targets. USAID was committed to supporting the TB programs in achieving its NSP strategic objectives. WHO said there has been significant progress, but this has been achieved by the COVID-19 pandemic. Uganda will need to revamp efforts to bounce back to previous case notification and treatment success rate gains. WHO is committed to supporting Uganda in working towards the goals by 2022. The permanent secretary, who was represented by the DG, appealed to everyone to reach the 90%, 90%, 90%, and 90% targets, especially in creating awareness amongst vulnerable populations and communities. The Ministry of Health will mobilize the necessary resources domestically and externally to ensure there is prioritization of TB activities. The Minister of Health on our side said this meeting was an opportunity for understanding the status of NSP year 2020-21 implementation. She appreciated the districts in TB emergency zones and other regions for good performance in case notification and treatment success rates. She called upon the health care workers to have vaccination against COVID-19 pandemic. She underscored the achievements made by NTLP in implementing NSP, and the Minister of Health then launched the CAS project, which you can see there. And of course, thereafter they took a group photo. What were the achievements of NTLP? This has to be mentioned because it was very important. One was expert network was expanded, including 16 model gene expert machines given to 7 regional referral hospitals. They have tested and piloted the electronic case-based surveillance network. Trainings are still going on, including this week and even next week. NTLP has procured diagnostics and artificial intelligence. NTLP has increased screening and diagnosis of TB. There is TB messaging and screening through the catch-up campaign, which has resonated the whole day and also yesterday. There has been orientation of DHOs to increase awareness and follow-ups. NTLP has developed people-centered national strategic plan. We have launched the multi-sectoral accountability framework. There is video conferencing equipment which was given to the regional referral hospitals and MDR sites for improved reporting. NTLP is coordinated TB response with procurement of motorcycles, soon to be given to the DTLSs. There is TB emergency response plan with increased case notification rates and TSR in the emergency zones, especially in Karamoja, Acholi, Lango, and the other zones coming. What were some of the key highlights? These are almost one sentences. Professor Sengoba was able to give us a keynote address, and he said domestic budget and external assistance for health is inadequate. There is need to expand domestic health financing, establish contributions to insurance schemes, and reduce off-budget financing. Dr. Garcia from WHO said health is a human right and not a luxury nobody can do without. WHO and partners call for redoubling efforts and investments to close the gaps. Dr. Stavia, our boss, said despite progress in finding missing TB cases, which was 40% in 2015, although reduced to about 25% by around this time, although there is some increase in case notification rates and treatment outcomes by this year, 2020 and 21. But there is still a slow progress towards achieving the United Nations high-level meeting targets. We were graced by MC Katz, and he said after he was diagnosed with the HIV, he realized that he was coughing, and he had TB, and the TB medicines only, he had to take them through syrups, and of course with the time, he found that if he could demystify the fear and stigma against TB and HIV, then he is able to recover. And indeed, he has recovered from that. The parliamentary caucus, on their part, said the fight against TB must be everybody's responsibility for government, communities, and families. You can contribute to ending TB in the country, and Uganda Parliamentary Caucus was enacted to broker and leverage resources to end TB. The Ministry of Gender, Labor, and Social Development said good health is a constitutional right and must be equitably distributed. Leprosy disease, if untreated, leads progressive to disability and stigma. Quality of life for such persons declines. However, centers of excellence, especially for leprosy management across country, have degraded, and there is need to revive these centers of excellence. The Uganda prisons, on their part, said African prisons are considered to have the highest burden of TB, attributed to overcrowding, rampant malnutrition, high HIV, inappropriate infrastructure, and delayed TB diagnosis. We were graced by the DHO of Yumbe, who was represented by one of the doctors, and who articulated that community sensitization on TB and leprosy by BRAC and IGAD and door-to-door screening for TB has paid off. The private sector, private facilities, said there is a call for incentives for the private facilities and also human resource capacity building. GLRA was represented by Dr. Kauma, and he said leprosy is present, and where there is leprosy in children, then it means there is infection coming from adults. Soon there will be a chance to offer single-dose rifampicin for leprosy contacts. From the academia, I have a question only, and from there was a lot of controversy. He said, realistically, it may not be possible to end TB by the year 2030, but he has been tasked to work on this and see whether we can do something. The 2020 TB communique reads like that. Our objective is to provide progress on the action points from the 3rd annual TB and Leprosy Stakeholders Conference. And from the previous conference, we said we needed to strengthen the implementation of Uganda Multi-Sectoral Accountability Framework for TB, MAF-TB. Consultative meetings are still going on. TB in the workplace was found to be a challenge, and also for these consultative meetings are still going on. There has been a negative impact of COVID-19 on TB service delivery, and amidst this, there has been continuation of essential services and development SOPs for COVID-19 and DSD model. There has been inadequate funding, training amidst great exposure to COVID-19, but we have had increasing access to COVID-19 vaccines. We have also had PPEs, and also we have got ACCM package, especially for creating awareness and communication strategies. This was presented by Dr. Maureen on behalf of the Principal Medical Officer. The communique went on and said there is limited community engagement in the TB response, and for this, the NTLP has targeted engagement of community stakeholders, especially by USP, with support from Global Fund. An orientation package for the CSOs and TB survivors has been developed. There has been TB-related stigma, and this is also being addressed. There is enhancing private sector engagement for TB control. This is also an ongoing process. The use of digital platforms to enhance TB control efforts, including during the COVID-19 era and beyond, is also taking place. Data management use, yes. There is engagement and involvement of the EOC in the TB emergency response. There has been operational research, including innovations, ongoing. And this has been articulated through the monthly NTLP Multi-Stakeholder Research Forum, which we have just listened a short while ago. There is also oral and poster presentations shared at the 52nd World Lung Conference, and we have been also graced by having a lot of these presentations on the sides of the wall. There are multiple studies with academia, and we are very grateful to them for presenting this today, although the time was a bit limited. There is 35% funding gap in the TB fight. And because of this, the NTLP has focused on government or Uganda funding for TB-related activities, including capacity building, medicines and supplies, printed and distributed the framework documents, that is the MAF, appointed technical officer to support MDS carry out agreed actions. We have updated the USAID roadmap and synergies leveraged, including community case finding and treatment support and diagnostics. There is inadequate resource and attention for TB, such as POC tests and shorter treatment during duration regimens. And yesterday there was a call to have the shortening from 6 months probably to 4 months. Other key highlights were, of course, MAF for TB, to provide progress on the action points from the 3rd annual TB and Leprosy Stakeholders Conference. From the Ministry of Works and Transport, there was a commitment of the Works and Transport Ministry that they will provide an enabling environment for raising awareness and conducting screening in public transport systems or networks. From NTRL, there will be a strong support from NTRL alluded that they have a strong support from NTLP and Ministry of Health to support TB lab network in country and sub-Saharan Africa. There was also that one of finding more TB in the communities, the CAS TB, amidst the COVID-19 response. TB and leprosy messages were disseminated, screening was conducted, and 1,578 people were diagnosed with TB. And around 95% of them were started on anti-TB medicines. Making TB agenda a campaign model and engaging local structures, the VHTs and its, community health workers, complemented to penetration of communities in search of TB. The Commissioner for Community said structures for implementation of CAST are in place and some of these people will be paid. And almost towards the end, we also had using artificial intelligence for finding TB. WHO recommends systematic screening using X-ray, which is equipped with digital technology. Diagnostic yield of TB among individuals screened from 5 sites is about 1.5%. Higher proportion of patients with abnormal X-ray confirmed with TB were 12% compared to 7% at community level. Global targets for zero leprosy. From here, we said countries with zero leprosy, new cases. The strategy has 4 pillars. We said countries must have 0 new cases. There should be reduction in annual number of new cases, reduction in rate per million population of new cases with grade 2 disability, and a reduction in rate per million children with new cases of leprosy. Some errors there, it will be corrected, and this was articulated by Dr. Rose Kengozi, our senior medical officer. The National Tuberculosis Agenda for Operations and Implementation Research was also talked about, and this one, we have been reported that it was embedded within the 3rd pillar of the NTB strategy that calls for research to optimize implementation and impact of innovative clinical and basic science research findings. Of course, there was the feasibility of incorporating interferon gamma release assay study. Latent TB infection screening at home with the IGRA was well accepted. 2/3 of the household contacts 5 years did not require TPT. Various barriers influence home-based latent TB testing. Home-based TPT resulted in high uptake and similar completion rates. I'll not go to the other details, but we had other research topics. There were quite many, but I think we shall be able to share those other findings on our computers and be able to go there. But I want us to finish with maybe the last one. A few key action points. 1, we need to rejuvenate neglected centers of leprosy management to their former prominence. That one came out yesterday. We are hoping GLRA, NTLP will take up this, and probably starting next year. Number 2 is to discuss with the government modalities of returning expert machines intended for TB diagnosis back to the health facilities of origin. And this one was tasked to the parliamentary caucus. Number 3, to use the 4th National TB and Leprosy Conference to market leprosy disease, because leprosy has been shrouded in silence, and leprosy has to come to prominence because it was there before TB. Number 4, we need to map and integrate private provider facilities into TB services. That will be the task of the private health providers. And I think this is also ongoing, and from next week onwards, I think the mapping process will take place. We need to engage the traditional or complementary practitioners in TB control, because sometimes communities visit them. We want to encourage door-to-door awareness creation, screening, diagnosis, and treatment, the CAS model for TB through the CAS model approach, and to support and engage VHTs and COPs for this model to work. We need to integrate leprosy into CAS TB model to ensure we reach zero leprosy target by the year 2030. We need to establish the MAF. There should be establishment of the MAF management framework to mobilize and solicit for funds from government for TB awareness, creation on screening, prevention, and management. And this was also tasked to the parliamentary caucus. We also need to mainstream TB and leprosy stakeholder conference with the major ministries. Some ministries have not come. We are hoping in the next conference, they'll be here with us. There should be integration of TB and leprosy activity development. The same, that is the responsibility of the CSOs, the Global Stop TB Fraternity. All the health workers should get vaccinated against COVID-19 as soon as possible. Improve access to short course regimen for treatment of susceptible TB.
The last 2 days putting together. So thank you, Peter, for this. I'm also working on assumption that you have been listening attentively. So what I only am going to request that let these things be put into what shall we be able to report when we get back here when we're doing the our fifth conference. Because this is now where we need accountability to see that we've spent the time here well. Otherwise we wouldn't come again, the same issues will do what? We now need to see that we have been able to address them. So this really forms like our aid memoir of the issues which have arisen out of the fourth TB leprosy conference. At this point in time, I want to invite Dr. Abel Nkolo to take us through his closing remarks for the implementing partners. So put your hands together to welcome the Chief of Party of Defeat TB, USA Defeat TB Project.
Honorable Minister, all protocol observed. Ladies and gentlemen, without implementing partners, there is no TB programming. Without implementing partners, we may not achieve many of the TB targets. Implementing partners provide extra hands and technical assistance to help the program move. Please raise your hand if you are an implementing partner. Yeah, and online. Thank you. Implementing partners need funds from the developing partners to support technical assistance and implementation. The implementing partners need coordination and guidance from the Ministry of Health and the National TB Program to be able to operate. The implementing partners work at all levels: national level, regional level, district, and communities. They work with civil society organizations, the private sector, and the other stakeholders. This is an important conference that brought together TB stakeholders to review the progress of United Nations high-level meeting, TB targets in the COVID-19 era. I would like to take this opportunity to thank the organizers of the meeting, the leader of the team, Dr. Stavia Tuliawe, and the chair of the organizing committee, Dr. Andrew Ochero, USTP, WHO, the Global Fund, SBCA, the events coordinator, Beatrice, implementing partners at large, and members from and the partners and the participants in this meeting. We thank in the special way the Minister of Health, the Minister of Health top management, and the Office of the Prime Minister for the great role they have played in keeping TB on the agenda. We thank the government and the American people for their support in ending the TB epidemic now for over 2 decades. As an individual who has also been around since 2004, around the TB program, this is the best conference that has been organized. Again, the role of implementing partners and the coordination cannot be overemphasized. I would like to share a personal story about being part of the government, implementing partners, and developing partners while dealing with the TB epidemic. In 2002 to 2004, I was dealing with the TB epidemic at a small health facility called Chibuku, which is formerly located which is located formerly in Palisa district. I was ensuring CB dots, setting up the laboratory, training microscopists, and registration of TB patients. I wanted to be at the top process supervisor to influence the policy and practice in the east and southern regions, covering 42 districts out of the 80 districts. That is half of the country by then, at that time. And I would like to thank Dr. Adatu for picking me up at that tender age. At that time, I was one of the youngest persons in the TB control program. I remember at that time as a country, we could do TB HIV in only 3 districts. That is Kiboga, Mayuge, and Rakai. I shifted to work as an implementing partner with Uphold in 2007. In less than a year, we spread TB HIV interventions to 80 districts. This is exactly what implementing do. I now work with URC, leading the USAID Defeat TB project to achieve targets. As implementing partners working with NTLP and other stakeholders, we have been able to influence many things. The role of implementing partners is evident in the achievement of NTLP, in the achievements NTLP is making. As a country, as we direct and coordinate IPs, we maximize their potential to achieve a lot in a short time. As you have heard in the conference, for example, implementing partners have helped the country to achieve the 100-day TB preventive therapy by reaching more than 300 people living with HIV and starting them on TB preventive therapy just only in 100 days. Actually, we smashed that target. Implementing partners have supported districts and countries to raise the case detection rate. This has been talked about in this conference, to increase treatment success rate, which had stagnated around 70s for a decade, and this has increased up to 84%. Coordinating multi-sectoral accountability framework together with WHO and the Office of the Prime Minister, coordinating research through the TB Research Forum, as you have heard in this conference, and piloting and scaling up the electronic-based surveillance system. I know the people who raised their hands can give more examples than I have given more examples than I have given. As the National TB LEPROSY program coordinates implementing partners and other stakeholders, we will be able to end the TB epidemic. Ladies and gentlemen, let me end with these important observations for our TB program. 1, we need an effective vaccine for TB. We have had the ineffective BCG vaccine for over 100 years. We need a vaccine that stops one from acquiring TB. 2, we need to shorten the regimens for TB. We have adherence problems with a 6-month regimen for susceptible TB, but also adherence challenges with the 11 to 20-month regimen for drug-resistant TB. Talk about the 4 or even 2-month regimen with moxifloxacin for susceptible TB or even rifampicin. We need an effective TB preventive therapy that takes a shorter month. We have adherence challenges with the longer regimen. Talk about the TB preventive therapy for 1 month or the 3 months of rifampicin. We need a 1-module gene expert that can be used at lower level facilities to eliminate the challenge. Started working on them. Our developing partners need to help in making sure they are delivered. The government, the National TB Leprosy Program, should meticulously coordinate this process. As implementing partners, we are ready to do our part. We are ready to help the country to accelerate the achievements of the United Nations high-level meeting targets and subsequently achieve the 2030 high targets. Together, we will end the TB epidemic 2030. Thank you, God bless you, and God, for God and my country.
Please, I know you have not had lunch, but a bigger hand clap And I really want to thank him for making this a really very big commendation, and also want to acknowledge the support from all our implementing partners in the room. Can we clap for them for supporting this area? So we are going to listen from Peter Locho, another project on scale TB, and you know in Karamoja, the incidence is about 10 times in the national average. So Peter, you speak to us on the perspective of the civil society organizations.
Hello. Thank you, Director Olaro. Honorable Minister, here represented by Director Public Health, Director Clinical Services, the Chief of Party of Defeat TB, other members, officials from the Ministry of Health, IPs, district leaders, ladies and gentlemen. I want to thank the organizers first really for this very important event. This has been really a very nice meeting, and we have discussed the issues that really touch our hearts when it comes to concerns around tuberculosis. I'm speaking in a number of capacities, I believe here. First, as the chairman of the Uganda Stop TB Partnership Board of Directors. That is the umbrella body for a number of TB support organizations in this country, civil society organizations. And, but I'm also the country representative of Doctors with Africa, QAM. That is an organization quite active in the field of tuberculosis. So I'm happy indeed to give these closing remarks. One will remain so for the next many years. And therefore, attention to TB is something that all countries, all governments need to put at the forefront. TB in economic terms, as you heard recently, or let me say, treating TB is one of the most cost-effective interventions. When you look at the gains you get from some measures of what economists call utility, be they QALYs, DALYs, or whatever, for every shilling or dollar that you invest in that treatment program. We have the technology and knowledge in the world to make a change. I know that resources are short, but we can get it done even with the resources we have. And I think we have had some of the simple examples of interventions that were not very high-tech and not very expensive that gave really good results. So we can get it done and really make the situation better for our country. As civil society, it is part of our mandate to advocate for resources. And advocacy goes to government and to the rest of the international society. And so as civil society organizations, I want us to make sure that this aspect of our role stands out. There are many things that Dr. Stavia and our team cannot say because of their positions, but we are a bit at liberty to a good extent to say some of the things, including being very critical of what government is putting on the table for TB. I want to thank the Ministry of Health, of course, through the program manager, for really the very good collaborative effort. We have enjoyed a very good collaborative effort as civil society organizations with the program, and this has really enabled us to put in our maximum, okay, for a good result to the fight against TB. Of course, the department has been supported by the able support from the directors and the minister that I know is very committed personally to the fight against TB. I want to say that Karamoja, when you saw in the maps, okay, has turned really largely from red to green. And I think this has contributed significantly to the elevation of the overall indicators for the country. So my belief is really that Karamoja is the rate limiting step for many things. And if we make the push in Karamoja strongest, we tend to lift up the rest of the country. So I want to thank all the partners, the districts, and the program for really getting it to happen in Karamoja to the extent that we have managed to push the rest of the country up in terms of TB indicators. In the early 2000, when Kuam was given, when Kuam won the Heroes in Health Award for maternal child health, when we were in Serena, there was, of course, this news went into WhatsApp groups and so on. And I remember Dr. Stavia telling me that, that now you have got maternal newborn award. The next is TB. But I want to say, as if she was like prophesizing. Of course, I did tell her that the next the guns are going to point at TB. And we indeed pointed the guns to TB. And the contribution is some of the results that you have seen. Of course, we won another award for TB this time during the TB Day this year in Moroto. So thank you for that prophecy and giving us, of course, the drive to really do what it takes to cause a difference in TB. Community action, I think it's very clear from this meeting that community action is probably the most effective response, or let me say something with the biggest gear in this fight against TB. If we make things happen at community level, we will reach our results at a much faster rate than concentrating on the traditional health infrastructure and system. So I want to call all the civil society organizations here present and those that will hear what we are communicating to really support this community effort for TB fight in the country, because that's where we shall get the highest mileage. CSOs have a much better advantage, or because of their flexibility, to reach the communities. And I want to call on all the CSO organizations in TB to really increase their level of effort regarding the community response for TB. I want to commend the new initiatives and pledge that we shall support them, including CAST, which has been launched in this meeting. I call on the CSOs in TB to support the coordination efforts through USTP. USTP is an organization that is really supposed to bring all of us who have interest in fighting TB together. But I must say, it has been struggling to realize that critical role. We know there are some internal challenges, but also I want to call on the organizations themselves to really support these coordination arrangements so that we can organize our support to fight TB more effectively. So our role as CSOs, I want to summarize, remains as advocacy, communication, resource mobilization, and I want to say also putting government to task, okay, as the other role. And we should, as CSOs, do this. On behalf of the CSOs, I want to pledge support to the Ministry of Health in the fight against TB at all levels. And I want to end here. Honorable Minister and directors here present, thank you again for organizing this day for God and my country.
I think I need to now to shift gears as we close. So first I want to make mention that the number of participants in the room were 170. Online there were 312 yesterday. Today there were 179. So let's clap for that. In the YouTube there were 78 participants. So before I invite the guests of honor, allow me to thank all the participants who are here. But I want to pay special tribute to those who have made us very comfortable here. First of all, I want to appreciate the rapporteurs. Let's clap for them. They could be upstanding with wherever they are. The rapporteurs. Thank you very much. The ushers, I think there's somebody who showed you where you were supposed to sit. They made, in a special, I want to thank the conference chair, Dr. Andrew Ochero. I don't know where he is. Thank you. And your co-chair, Dr. Paul Isiko. There was an event coordinator, Beatrice. The IT support, particularly if the ones in the online would not have been able to follow up, and I think I have not received any complaints from the members of online, Mr. Ronald Musambo and your team. Okay, so, and then the media. So I'm sure everybody who is here, his photograph was taken. If you need it, just ask me and you'll be able to get your copy of your photograph. I would now at this point, definitely I want to acknowledge the NTPL, the Uganda STP, the USAID Defeat TB, USAID SBCA project, and PACE. I want to ask Dr. Chero and his team, because we now have to go through recognitions of the people who are going to get certificates, and thereafter I will invite the guests of honor to address us. So let's make it faster. I know the food has become cold. There were people who have lost appetite. But afterward, we are going to have a prayer which will bring back your appetite. So let me invite the representative of the Honorable Minister, Dr. Daniel. You come forward and hand over the certificate. I think the certificates are few. Let's get everybody who is here get his certificate. It's good that they receive their certificates. So the first person will be Dr. Andrew Ochero for having chaired Lamour district on this occasion. I don't know the Lamour is on. Kanungu. Fort Photo City. Lamour. Luengo. you'll miss the chance to get a certificate from the Honorable Minister. Rwampara District.
Which district?
Oh, this is a city where I lived for 10 years. Butambala District. Butambala. Rwampara. Shema. Impiji. Because this is actually where the actual service delivery takes place. Apache. Budaka. Iganga. Nakasongola.
Which district?
Budaka.
This is Budaka. Kanung is coming.
Nakasongola.
Iganga.
Nakasongola is here. Oyam. Rakai. Do you have Rakai?
Rakai, Oyam.
Sembable. Please come. Madi Okolo.
The claps have reduced. Please clap for this very great achievement. Dokolo.
Dokolo. You need to pronounce it properly.
Congratulations.
Obongi.
And which district? Madi.
Madi Okolo. Oyam? That's the Sembable. Sembable. Obongi.
Bongi.
Tororo. I'm also doing a census who is still in the room.
Tororo.
Bushia. Are they finished? I think so. The rest we can.
Kanungu.
No.
No one. Who was outside? Okay, we've missed shaking their hands. Oyam.
Okay, so ladies and gentlemen, I want to congratulate all those who have got certificates and all the others who have not got their other certificates. At this point in time, I would want to officially welcome the representative of the Honorable Minister to make the statement on behalf of the Honorable Minister, and thereafter close this fourth National Tuberculosis and Leprosy Stakeholders Conference 2021. Let's put our hands together and welcome Daniel.
The representatives of the different diplomatic corps here and who were here yesterday, the US ambassador, the RDCs who are still here, and those who were here, members of parliament and your caucus, representatives of the World Health Organization, the Director Clinical Service, also representing the Director General, the private health providers, civil society, COW, district health officers, and those who have received certificates for their colleagues, the LEPROSY program officer, officials from the Ministry of Health, health workers, all invited guests, physical, and those on Zoom and on YouTube. The number was overwhelmingly when it was read. Ladies and gentlemen, I want to read to you the speech for the Honorable Minister of Health as provided today. And I'm sure she would start with the following statement: I want to appreciate you all for being here until now. It is very tempting to look at your watch and walk away. You've taken a long time before you've had your meals, so I really want to appreciate you on her behalf. Good afternoon, all of you. I would like to congratulate all those who have attended this hybrid conference. I should say it's been fruitful and successful conference, given the numbers and the milestones. I want again to give credit to the organizers for all the time they have taken and the effort put in to make this meeting a success. Please, let's clap for them. In addition, I want to appreciate the World Health Organization, the Global Fund, the Global Stop TB Partnership, our own Uganda Stop TB Partnership, USAID, Defeat TB Project, URCCHS, CDC, the PACE, and all others who have made financial contributions to support this conference. Thank you very much. Further, I want to appreciate the partners who have sponsored the participants from different regions who have been able to follow the conference virtually, and those who are physically in the room to participate in this conference since yesterday. Once again, I want to give a special recognition of all people who have made presentations, both physically here and those who spoke to us virtually or sent their recorded presentation. In a special way, we want to thank the keynote address speakers, Professor Freddy Sengoba and Mrs. Ines Gracia Bena. Allow me also to appreciate the panel discussants. Honorable Joel Sebikali, Chair, Parliamentary TB Caucus, Canon Dr. Johnson Byabashaija, Commissioner, Uganda Prisons Services, Dr. Herman K. Joseph Kauma, Dr. Katamba Achilles, Makerere University, Mr. Juhaza Zubari Chisambira, Dr. Yai Alfred of DHO Yumbe. Finally, I wish to thank the exhibitors and those who shared evidence in TB work in their research and diagnostic innovations. I can't conclude my speech without taking note of the people who have just been awarded for the outstanding performance in TB for the financial year 2020-2021. Let's clap for them. I therefore encourage all of us to aspire to do better. Like you heard in the presentation, we will not be using the traditional two indicators to gauge performance. And I guess the rest of you are very familiar with that. This is going to be a culture of Ministry of Health, so prevention is very key if the end of the epidemic is to be realized. This is going to be the culture of the Ministry of Health to use this annual conference to resolutions for the outstanding performance and contribution to the fight against tuberculosis and leprosy. Go and work hard. You'll surely be recognized. You may have noted the need for multi-sectoral collaboration again in this conference. I call upon all the relevant stakeholders and agencies to undertake seriously your roles as stipulated in the multi-sectoral accountability framework for TB. In a special way, I want to appreciate the other ministries who joined us in this annual conference this year. It shows commitment to this country and development towards ending TB as a public health problem by 2030. In addition, ladies and gentlemen, having noted the benefit of community engagement, we have launched the CAS-TB approach that was done yesterday. The implementation of this approach requires your support in terms of bridging the funding gap and implementation. I call upon the district and local governments and political leaders to ensure every home is reached when implementation of this starts. It will be repeated every 6 months until we have ended TB as an epidemic in this country. It is pleasant to note from the presentation today from Dr. Eliud Wandalo of the Global Fund in Geneva that Uganda has been recognized by the Global Fund as one of the key TB programming performers globally by meeting the targets for detecting more than 80% of the incident cases of TB in spite of the COVID-19 pandemic. I add my voice again to applaud the National TB and Leprosy program staff for the great work being done. I think they even deserve a bigger clap from all of us. Finally, once again, I would like to remind you to observe the SOPs for COVID prevention, request you to complete your vaccination if you've not yet achieved it, and this to join me in the campaign to vaccinate all the priority groups in Uganda. Thank you everyone for participating, and therefore I take this honor to declare the 4th National TB Leprosy Stakeholder Conference 2021 closed. Merry Christmas and Happy New Year. Allow me to ask you to stand up and we clap for the minister for delivering her speech. And I would wish to invite the organizing committee to come and have a photo with the Honorable Minister. And I sign off, Dr. Honorable Jane Ruth Acheng Ochero, for God and my country. Now put on my mask and sanitize.
Organizing committee quickly, and the districts with certificates after the organizing committee reach near, show you up.
Where do we start?
Eh?
When we have some, if we need to take away the podium, then
We'll take away the podium.
yeah, take away the podium.
You take this away.
You won't start with the minister.
The minister for this moment.
Honorable Minister. You know the minister personally.
Now, Peter, you need to come with your certificate and